the board meeting of the Mendocino Coast Healthcare District to order. So first item of business is public comment. Oh, I'm sorry. Call the roll, please.
Okay, Paul Garza.
Here.
Paul Katza.
Here.
Susan Savage here. Sarah Spring.
Present.
Okay, why are we hearing an echo?
We'll get there.
Okay. We'll wait just a moment so that it's a bit distracting. Are we okay now?
Yes.
Okay, good.
Recording in progress.
Okay, so let's go on to public comment. Any items not on the agenda? Mr. McDonald?
Malcolm McDonald, Little River. I don't usually bother to say that, but when a fellow resident of the coast called me more than 2 weeks ago about receiving one of these, and I hadn't gotten mine yet. So anyway, long story short, when I went to get mine, I looked in the trash bin, and they were already, some people tore them in half. This is from going to Little River 2 times, and Albion once, and then one.
Excuse me, Mr.
Gathering.
McDonald, would you please not throw things on the floor? I think that's very inappropriate.
What you think is inappropriate and what I think are 2 different things, Mr. Garza. So I just want you guys to know that's what, a lot of people did with theirs. Beyond that, I would imagine probably early April when there were community meetings in the Fort Bragg area, Mr. Garza recruited Chris Hart of the Mendocino Railway Company to apply for the open seat on the board. He can shake his head all he wants, but I could, play recordings and et cetera. Anyway, a couple of weeks later, he got cold feet about Mr. Hart. Maybe he didn't know who he was, that he was one of the owners of Mendocino Railway, AKA the Skunk. I think that's probably largely tied to Mr. Garza's already made a decision about wanting to have a bond measure on the ballot this year, and he might have viewed Mr. Hart as, somebody who might be divisive for that vote. Anyway, that takes us to the board meeting where a vote was, where interviews were held for a new board candidate, somebody to fill the vacancy from Lee Finney's resignation. We should probably even go back to late September when Mr. Garza got on the board in a board election that was initially a 2-2 tie between himself and Mr. Maroney, who, as almost always, is here at the meeting. So kind of, and at that meeting, when the vote was tied 2-2 and there was some confusion about things, and one of the other board members tried to do something gracious to allow both of them on the board. Anyway, things were confused. Eventually, Mr. Maroney took the high road and stepped aside. So when we got to the April meeting to elect a new board member, Mr. Garza deliberately fashioned his questions to Mr. Maroney, who was another candidate along with Mr. Hart, anybody sitting here who followed the meetings knew that Mr. Garza was sticking it to Mr. Maroney, saying, we're not going to be picking you. thank you for your participation. The result was, at that meeting, Director Katzef voted for Mr. Maroney. The other two members present, Mr. Garza and Ms. Savage, abstained in what appeared at the time to be a deliberate move. I mean, if you abstain, it's an action, so it inherently is deliberate. That caused the election to then be thrown to the Board of Supervisors. So over this weekend and published on Monday came a chair report from Mr. Garza welcoming Ms. McGorty to the board. Well, that's nice. Ms. McGorty is a nice person, or thoughtful person in my humble opinion from past dealings with her. The problem was that the Board of Supervisors hadn't met yet and taken the vote on whether or not Ms. McGorty would become the board member.
Time up?
So,
Don't interrupt him, he's saying important stuff. You can have my time.
No, you don't have, it's 3 minutes, Paul. We have to observe 3 minutes.
No, we don't.
Yes, we do.
so
You're out
what
of
we have
time.
here is
So
somebody
finish
who's
up, please.
predetermining everything, including writing a letter to the public welcoming Ms. McGorty to the board when the process had not even taken place yet. This is the person you have as your chair.
Okay.
Thank you.
Okay. Do we have any? Okay, I'm going to declare a short recess so we can pick these things up before we go on with our business, because oh, you're going to do it? Okay. Thank you. Okay, any more comments from the public at this point? Okay, thank you. Let's move on to my report to you. Yes, indeed, I'm pleased to welcome Ms. McGorty tonight. We were a little unsure about the process. When I was appointed to this group, I was able to be sworn in on the same night and begin my duties as a voting member. Apparently, because of what?
It's fine.
Okay. But apparently when it's, the appointment is made by the Board of Supervisors, it's different. So she will be completing a form and turning it into the Register of Voters. So we expect at our next meeting that she will be eligible to vote. So right now she's just a participant. Anyway, she has an outstanding background. She served this county for a long time, mostly in behavioral health, which is her passion, I understand. She also has a master's degree in public administration from the University of San Francisco, and so we look forward to her participation. Now, let's move on. We've spent an inordinate amount of time trying to deal with the finances of this organization, and considering the fact that our primary role is to manage taxpayers'
Was
dollars.
there any other public comments?
Pardon?
Were there any other public
No,
comments?
I didn't, there weren't any.
No other public.
So where was I? Okay, over the past 4 months, we've been working on this, and we've gotten some outstanding results. I'm really pleased to announce that for the first time, at least, I think we can really track our finances. The number of our bank accounts that the district had has been reduced from 25 accounts to 2, okay? Our banking fees have been reduced from $7,000 a quarter to 0. Our district reserves are now earning either 4.2% in the local agency investment fund or 5%. Well, that's a slight exaggeration. It's actually 5.364% per annum on 4-week treasury bills that enable this to be liquid, and which we can move out of them as quickly as we need to. Now, please note that the majority of the district reserves are in treasury bills, and our CFO's financial report will give you some exact numbers a little bit later. All of our taxpayers can expect a much better return on their tax investments as a result. Additionally, all taxpayers' funds are now in accounts or investments that are fully guaranteed as required by California law. And lastly, there are now a minimum of 2 eyes on every single district transaction, which is a universally recognized best practice. The investment and banking policies followed by earlier boards created a number of serious problems potentially for the district. First, there was a labyrinthine-like administrative difficulties managing and accounting for funds, and we were never able to, at least as when I've been on the board, get a reliable figure about how much money we had and where it was. And then secondly, a complicated and therefore unnecessarily expensive processes for financial audits. And lastly, given that many bank accounts, an ideal environment for fraud and embezzlement. So we have some additional good news. Many of you who have been following the board closely know that last year there was a $1 million erroneously deposited in an intergovernment transfer fund. Those funds have been recovered by the district and have now been deposited in district accounts. Additionally, we have also recovered a check of over slightly $202,000 from the closure of Bank of America accounts that was missing from us for about 100 days. Those funds were deposited last week in district accounts, so we've moved on. These above improvements in our finances indicate dedicated and exceptional work by our district staff, and I want to thank them for their work on this. On the negative side, we have found that the district may have a liability of as much as $1 million for federal COVID relief funds that were received on behalf of the hospital in 2020. It appears, and we're in the process of trying to determine this, that inaccurate reports were filed by the previous board, regrettably. Like I say, our CFO, Mr. Wayne Allen, is working to resolve this concern. We'll provide you more information, obviously, as we get to it, and he's going to discuss it in a great deal detail during his report. Okay. Let's move on to legislation. The California Senate Bill 1432, authored by Senator Caballero, as proposed, would extend the date of seismic compliance for all hospitals to January 1st, 2023. And under certain conditions, offer some financial relief for rural and other financially stressed hospitals. 2023? 2033, okay, excuse me, my error. Wow, we didn't catch that. 2033. So give us 3 more years. Fortunately, the bill passed out of the Senate Appropriations Committee last Thursday, and I understand now it's in the Assembly. I thought it had to go to the full Senate, but I was corrected that it's now in the Assembly. There is a strong belief, which may or may not be true, that the bill will be amended to include relevant portions of Assembly Bill 869, which was introduced by our Assembly member, Jim Wood. The point is that we need to be watchful of this legislation, and we will continue to monitor this progress of it, because if passed, it will have a very substantial impact upon our hospital. This recent legislative activity, in my view, strongly also indicates our need to become much more actively involved in monitoring legislation and providing regular education and input to the California legislature on matters that affect us. This should include, in my view, evaluating our district's current association memberships and other affiliations that we may have to assure that we're properly and appropriately informed and represented. Perhaps we should also direct district staff to report regularly on important legislation affecting our district. And lastly, I believe that we should maintain regular legislative updates on our website to enable better information to our community, to all of you. So lastly, I want to talk about our community forum, the health forum that will be next week, a week from today at Town Hall in Fort Bragg. This event will feature a detailed analysis of data on the health status of our community from a report composed by the California Center for Rural Policy. That report has been on our website. We wanted to make it available to anybody who was interested for some time. Now, I'm pleased that we're partnering with the Mendocino Coast Healthcare Foundation to present this event, and that the Latino Coalition has also joined as a sponsor as well, and we will be offering Spanish translation for those who require it. Following the presentation by the CCRP, key community health leaders will share their perspective on the data in a panel discussion. Then, immediately following that, the public will be invited to submit questions to the panel. This event will be available for viewing online and will be recorded and posted on our district website. I want to encourage all community members to view this important discussion, which I hope will be the first of many about improving the health of our residents. Okay. So with that, let's move on to, I'd like to recognize item 3B, Julia Drefke of Government Affairs. Is she available online?
She's here.
Yeah.
May I introduce?
Yeah,
the
please.
group presenting on behalf of Adventist Health? Thank you. Good evening, District Board. We are pleased to be able to bring you some information about House Bill 1432, and I want to introduce Julia Drefke, who will be listening in on a conversation that we are presenting tonight with the California Hospital Association. Very pleased to introduce to you Megan Harding, who is Regional Vice President for Hospital Council of Northern and Central California, along with Brian Bucklew, who is President and CEO of the Hospital Council, again, for Northern and Central California hospitals. They are both on the screen with us tonight, and thank you for allowing us to have a few minutes to give you an update.
No, thank you for making them available, Ms. Leach.
Thank you, Mr. Chairman, Judy, and members of the board for having us this evening. I have to start by saying it's really an honor and a privilege to work with dedicated leaders like Judy, and your community is very fortunate to have her leadership. We're grateful for the opportunity to be here tonight. My name is Megan Hardin. I am a Regional Vice President with the Hospital Council of Northern and Central California. I serve hospitals in the northwest part of our state, including Mendocino Coast, and I'm joined by my CEO, Brian Bucklew. The Hospital Council, together with the California Hospital Association, advocates on behalf of our members so that they can focus on their most important work, serving and safeguarding the health of their communities. Judy's timing asking us to share seismic updates with you is pleasant. As my father might say, our legislature is really moving and shaking on this topic right now. And I just knocked all over with laughter. I heard one person. Okay, no. Put aside, if we were speaking with you this past Monday instead of today, I would have a different report entirely. So before I provide the update, I have to include two specific caveats. First, both bills that I'll reference tonight are evolving, and there will likely be further adjustments. Second, the key points of the 2030 legislation remain unchanged. The district must invest in ensuring their facilities remain fully operational following an earthquake. What we are advocating for is more time for you to accomplish this. So as a quick refresher, in California, hospitals are required to meet specific seismic safety standards by the year 2030, as mandated by legislation enacted in 1973 following the Sylmar earthquake. Key points for 2030 include operational. So by 2030, all acute care hospitals must be fully operational following an earthquake. Retrofit or replace. Hospitals must either retrofit existing buildings to meet these standards or replace them with new compliant structures. And seismic evaluation. Hospitals are required to undergo detailed seismic evaluations to assess their current level of compliance and plan necessary upgrades. As Mr. Chairman mentioned, failure to comply with these regulations by the 2030 deadline could result in the closure of non-compliant facilities, significantly impacting healthcare delivery in the affected regions. As you all are aware, significant retrofits or replacement are big expenses. And as a result, the California Hospital Association has been working for over a decade to both ensure patient safety and, importantly, safeguard patient access. The two bills of most consequence for Mendocino Coast District Hospital are Senate Bill 1432 and Assembly Bill 869. So to provide a quick breakdown of each, although Mr. Chair, you did a great job already. Starting with some excellent news. Senate Bill 1432, the hospital seismic extension bill, moved out of the Senate yesterday with near unanimous vote. The bill now moves to the Assembly for further debate, negotiations, and discussion. Senate Bill 1432 is CHA, California Hospital Association's proposal to address the 2030 seismic requirement. The bill would extend the 2030 deadline, address additional post-earthquake disaster preparedness requirements for hospitals, assess opportunities for financial support, and require the state to assess the financial and access impacts of the 2030 requirement. If you have to rebuild significant parts of your hospital, you will have to close significant parts of your hospital. That means patients can't be seen. So what does this look like practically, and how can we partner together with the state to maintain continuous access for your patients? And address rural hospitals' unique concerns. This bill proposes extending the deadline for hospitals to meet seismic safety requirements by 7 years, from 2030 to 2037. The extension aims to provide hospitals with additional time to comply with the stringent seismic safety standards, addressing the financial and logistical challenges many facilities face in retrofitting or replacing their buildings to meet these requirements. The bill was amended to strengthen transparency at the local level and remove the rural hospital provisions to align with Assembly Bill 869, which is the second bill we'll discuss. Assembly Bill 869, from your very own Assembly member, Dr. Jim Wood, would prioritize certain smaller hospitals for the existing Small and Rural Hospital Relief Program, which is funded by the e-cigarette tax. This would allow them to get assessments for the cost of retrofitting their hospital and give certain small rural hospitals and certain district hospitals a 5-year extension of the 2030 seismic deadline. It would also allow certain smaller rural and district hospitals, if they have experienced a financial hardship, name me one that hasn't, an indefinite extension beyond 2035 until funds are appropriated by the state. Amendments taken on March 7th provide additional criteria that healthcare districts can be eligible for the extensions under the bill. Assembly Bill 869 is still waiting to be heard in Senate Health. We hope that the administration will be providing amendments in perspective next week, and this will kind of guide next steps in terms of our advocacy. We are directionally supportive and working with Dr. Wood's office. We will update our membership as soon as we have material updates. And in the meanwhile, our ask of anyone on the line tonight is to please keep writing and calling Dr. Wood's office and all of your local elected officials to let them know how very important AB 869 is to the continued provision of healthcare on the Mendocino coast. Thank you for your audience, and Brian and I are happy to take any questions you may have.
Okay, thank you very much. Appreciate that. And it's really good news that it moved out of the Senate today. That was very, very good. Questions from the board? Director Savage.
Yes, thank you for being here. I got online and watched one of the hearings that was on YouTube for the Senate Bill 1432. And what was interesting to me is there were, I'm not sure, demands, encouragements, et cetera, to amend the bill to include penalties other than just the threat of closure if certain timelines were not met. And I don't know if those requests for amendment went anywhere, or is the bill still pretty much intact from when it was introduced?
Brian, you may know more than me. The most significant revision I know of is the removal of the special rural hospital caveat from 1432 to better align with 869. But do you know, Brian, if additional penalties were added to the language?
No additional penalties were added. There was a concern and a desire by the Assembly to make sure that it just wasn't a blanket extension without any that there was a plan in place and that there was transparency that the hospitals were making strides towards seismic compliance of those 2030 standards. So I think those questions that you heard and those potential amendments were geared towards making sure hospitals were being transparent in terms of the due diligence and making sure that they were going to be compliant with the 2030 standards, whether it's in 2035 or 2037. On the second bill, on Dr. Wood's bill, Why that's particularly important for the health district is that there is some definitions on what hospitals would be eligible for some potential grants that to become seismically compliant. And as of right now, the health district would be eligible for those, and that's why it's critically important to continue connecting with Assemblymember Wood. And Dr. Wood's been a very big supporter of trying to find a remedy for hospitals that are in areas that are serving very vulnerable populations, serving rural populations, and also may not have the resources available that some other hospitals or hospital systems have. So I think it's very good news. This is further the furthest that a seismic bill has gone in the past decade, and we're cautiously optimistic that we'll continue down this pathway.
Other questions from the board?
Okay, I have one more then, if nobody else does.
Go ahead, please.
Okay. At one time, I had heard that one of the places where there were concerns expressed was in the governor's office. Are you hearing any indications in terms of how Governor Newsom may be dealing with this bill should it come to his desk?
Well, you never know until something actually gets passed. In the past, there's been a bill, particularly with Alameda County, that would grant Alameda Health a 2-year extension. The governor vetoed that bill from the seismic compliance, and because his belief was that the issue needed to be dealt in its entirety, that it shouldn't be a piecemeal approach where one hospital would try to get some legislation passed to be exempted or have a time extension. We thought it should be across the entire industry. And so that's the goal that everyone's been operating under. I know the Senate president and the speaker have been working with the administration as we have, and everybody's supportive of this collaborative effort. Once again, it's not, I don't want to say it's not a hospital issue versus a labor issue. It's really how do we keep those hospitals operational? How do we keep those service lines available and making sure that they're available for the people that rely on them, and so people can get the care that they need when they need it, where they need it.
I got a question.
Director Katzif.
It seems to me that it is a real important labor issue when it comes to contractors. If there's 100 hospitals that need to be retrofitted or more in a short period of time, where are all these people going to come from who are going to do the work? Is there any kind of training program that's happening in advance of this grand construction period that is going to train people or construction companies to deal with a very special kind of construction, hospital construction with all its regulations and rules? So for me, looking down the road, it's all going to pile up at once. And this community is going to be, whoever's here is going to be recruited elsewhere for a whole lot more money. And we're going to be stuck with not the labor force that we're going to need to do the work if all that labor is been bought out of the community because other communities can pay higher wages, and et cetera. What's your thought on that?
I could not agree more. I think it is a big challenge. It's one of those issues that I would definitely raise with our elected officials. It's issues that we've raised with our elected officials. I think we've had hospitals in rural communities that have put to bid certain projects and have had 0 bids come back. And that's before this big building boom for the seismic compliance would come into fruition. So I think the construction industry and the service industry is experiencing some of the same challenges that the healthcare industry is in terms of workforce. So I don't have a good answer for you, and I'm not aware of particular, training programs that is geared towards the seismic compliance. But having enough workers and having the workforce and able to do all these retrofits and new builds is a big concern, and that's why it's not a panacea to have this 3-year delay or a 5-year delay, because construction costs, supply costs, those continue to go up, and we're still going to have to remain compliant with those seismic regulations. This just gives us some more time to deal with that issue. But it's a great question, and it's a question that I think our elected officials have been asked and should continue to be asked.
Any other questions from the board at this point? Okay, thank you very much. We really appreciate you making your time available to brief us on this. Clearly, it's very important. We very much appreciate Adventist Health helping us to enable you two to be here. You know, we're going to get much more involved, hopefully in the future, of staying on top of this and participating. I think we're appropriate, providing our role as educators to the legislators about how things affect us. Anyway, thank you.
Thank you.
Thank you.
Thank you to Megan and to Brian for their presentation. Again, the presentation that was planned on Monday totally changed within the last 24 hours as a result of what the state has brought forward. So once again, the next step that we all have the opportunity of engaging on is contacting Dr. Woods and letting him know how we feel. Once again, what happened in that overwhelming vote is a good thing in that we're not under the same time restraints. However, what I am hearing the Hospital Association say is that it just kicks this down the road a ways. It means that we have the potential of a latitude of a greater amount of time to which to address the issue. The issue of this building will continue to be one where ongoing repairs are needed while the seismic conversation continues. So I'm going to ask in conclusion, Brian, if you had to sum up the results of what was just voted on today for those that are just entering the conversation, if there were one or two sentences to do that, what would that be, Brian?
Well, I think it is, I think you outlined it very well, Judy. I think it's an opportunity to work with HCI. It's an opportunity to work with our elected officials to make sure that the investments that are needed in the hospitals are identified and also financed. And that's where I think Assemblymember Wood's bill is going to be critically important, because there's some dollars that are potentially attached to that could be helpful for health districts like yourselves. But it doesn't abdicate the hospitals from the responsibility of complying with the 2030 seismic mandates. And so those are going to have to be done. And this just gives us some more time to plan. And hopefully we'll have some additional financial vehicles through some of the other legislation that's being considered.
Okay, again, thank you very much. So let's move on now to a presentation from HCI, since they've been already cited. We have the pleasure of welcoming Carl Schurman, who's a senior policy advisor with the, and again, health. Why I can't remember the initials. I'm sorry.
Hospital care and information.
No, at the conclusion of Mr. Sherman's remarks, will take about 20 to 25 minutes.
Yeah,
I am going to do the extraordinary thing of opening it up for questions from the public. Kathy, Ms. Wiley, you have the note cards here for people?
Yes.
And we're going to ask you to write your questions. Those of you who are online, please put them into chat, and our clerk of the board, Norma Alley, will note that. And we'll try and get as many answered as possible. I don't believe we'll probably answer all your questions tonight, but for those that are left, we will do our best to get you responses as quickly as possible. We wanted to make this available. There's been a lot of discussion, a lot of concern, so we thought it would be really best to hear from the agency that we're working with and give us the best insight about where things are right now.
Thank you, Mr. Chairman, and members of the board. My name is Carl Scheuerman. I'm with the Office of Statewide Hospital Planning and Development, office within the Department of Healthcare Access and Information, or as you heard earlier, HCI is our name. My duty is to serve as a policy advisor on matters related to seismic, and the things that you heard today are things that I'm very actively working on behalf of the state. But we're not here today to talk about legislation. We're here today to talk about your hospital and about the seismic compliance for the hospital. In 1971, the Sylmar earthquake was a call to action. Oops, sorry, just a minute. I have to take something off this. Oh, I guess not. All right.
Excuse me?
The Sylmar earthquake resulted, I'm sorry.
No, I just was going to ask if we could get rid of that right in the middle of the.
Yeah, that would be helpful. Thank you very
No,
much.
no, no, the
The
low
low
system
system
resources.
These are the low
Can
system
you click
resources.
on that?
In the middle.
Ta-da, thank you.
Thank you very much.
There we go.
Sylmar was a wake-up call. The brand-new Olive View Hospital you see here crumbled right after its opening. And that was a note to the state that the actions that they had taken in the 1930s for schools to make them earthquake-safe now needed to also be applied to hospitals as well. So the Alfred E. Ahlquist Seismic Safety Act was adopted in 1972 following the Sylmar. And the statement in the law is hospitals that house patients who have less than the capacity of normally healthy persons to protect themselves and must be reasonably capable of providing services to the public after a disaster in the world. I'm sorry for the technical difficulties. Shall be designed and constructed to resist insofar as practical the forces generated by earthquakes, gravity, and winds. And the phrase insofar as practical is important because while we strive for perfection, we know that it's not possible. So what is a hospital? What is hospital functionality? It requires a structure, consists of beams, columns, shear walls, slabs, and foundations, and we refer to this as the structural performance category of a hospital, or SPC. The non-structural elements, cladding, partitions, ceilings, equipment, pipes, furnishings, contents, the things that are in the building are considered to be non-structural performance category. And of course, no hospital can operate without staff. So we see these as being the three cornerstones of resilient operations. So what is SPC? Seismic performance categories fall into two groups, the pre-1973, post-1973. Before 1973, all hospitals were permitted by the local jurisdictions. And while they were required to follow the building standards at the time, the enforcement was somewhat lax, and the standards were not very strong at that time. Following the Sylmar, earthquake, the science advanced and the requirements for a seismically conforming building advanced at the same time. An SPC1 building is basically a collapse hazard building. And we still have a very few of them in the state that are being resolved right now through a process known as AB 2190, which is an extension for SPC1 buildings. And these are all to be removed from service not later than January 1st of 2025. Originally 2020, originally January 1st of 2008. But as you can see, the result of extensions over time has allowed these buildings to continue to operate past the time it was anticipated. An SPC2 building has a low risk of collapse in a major earthquake, but it's built to what we would call a commercial standard. The importance factor that the structural engineers use to calculate this is 1, which means it's no more important than any other building, as opposed to a hospital where the importance factor is 1.5. So clearly, a hospital building is required to be much more durable than an SPC2. We have basically 4 categories of compliant buildings that are reasonably capable of providing services to the public after a major earthquake. SPC3, which is no longer a category for new facilities. It's called a pre-Northridge hospital. Northridge showed us that while they were better and repairable than an SPC2 building, they weren't as good as they should have been, and we learned from that. SPC4 and SPC4D are the standards that were in place beginning January of 1980. And so the SPC4D category is one that a building can be retrofitted to from SPC 2, and it's not required to meet a 2020 standard. It's required to meet a 1980 standard. And this is important because we'll talk about how those buildings would be affected here. SPC 5 is for new construction, and so all buildings that are built to current code are SPC 5. So SPC 2 buildings do not significantly jeopardize life. They're not hospital grade, as we noted, and these are national standards. SPC 2 buildings are considered life safety only, but that doesn't mean that you're able to provide care in them following an event. They may still have structural deficiencies, and they may be damaged possibly beyond repair, may not be capable of providing services to the public after a major event. Your time to recover is something to always consider. How long will you be down if something happens to one of your buildings? We're definitely an earthquake country, as you can see from the fault map. So regardless of where we fall on that map, we can expect there to be an earthquake in California. Now, primary building structures able to resist anticipated ground motion forces are specific to each building's exact location. We've heard over the years that the seismic compliance requirement is a one-size-fits-all program. It is not. The performance standard that you meet is equivalent, but the performance is specific to the ground that you sit on, the soil and the relative seismicity. And we know what the soil is like because a geotechnical engineer must take a sample and provide those values to the designer. And the seismicity is established by the federal government. So those standards that we adopt without modification. It only needs to demonstrate resiliency for the conditions that it sits on. Each one is unique. So if you're in Fresno, you're going to have a building that is less than a building in Napa, and that's going to be less than a building in Los Angeles. So again, it's relative to the specific condition on the ground. So what does that mean for Mendocino Coast Hospital? The fact is, and we look at the factors that are used by structural engineers as a way of measuring relative risk across the state. Of all the hospitals in the state, Providence St. Joseph Eureka has actually the highest risk, whereas Colorado River and Needles has the least. The thing that I want to point out here that is most important is that, while you are less active than Napa, you're more active than Fresno. So where Mendocino Coast Hospital sits is pretty much right in the middle. And you see mathematically, it really is in the middle. So the thing is that while you do have a risk from earthquakes, it's not as bad as it is in many other locations. This is important when you start planning your retrofit because your retrofit needs to respond to the conditions that you have here. Now I'm going to talk about non-structural performance for a minute. And these are actually progressive as opposed to the SPC. An NPC1 facility is simply non-conforming. There's nothing in it that is braced. An NPC2 facility has certain elements of it that was braced to support evacuation. NPC3 braces things in clinical areas, NPC4 throughout the hospital, and NPC5 is a provision of 72 hours of utilities throughout for water, for sewage, and for fuel. So the purpose of the NPC is to keep things from falling and from breaking. As you can see here, that if any of these things are dislodged, then operations is going to come to a halt. So position retention is the key to NPC. So I'm going to show you what this means. This is a hospital. You can see the different functions that are going on inside of a hospital, including the utilities. Your med gases, your emergency generator is every bit as important as the clinical equipment in the hospital. NPC2 braced the bulk oxygen, the fire alarm panels, the generators, the exit lights, those kinds of things to support safe evacuation. NPC3 does position retention, bracing in critical care areas, ICU, surgery, radiology, a number of other locations to be sure that those services are not harmed by things that got moved. Oops, where are we? NPC 4, oops. NPC 4 takes the whole hospital and braces it. And NPC 5, as noted before, provides for 72 hours of water, 72 hours of fuel, and 72 hours of sewage storage. This is what bad happens in an earthquake in a hospital if things aren't braced. Now, this picture was taken following the Turkey earthquake last year. And by the way, Turkey's seismic profile is very similar to that of California. We have a whole presentation on that that we've given to the Secretary of Health and Human Services Agency. But the fact is wherever you are in the world, if things are not position retained, then this is what you get. And you cannot operate in this condition. Now, there are deadlines, as was mentioned before. Any hospital building intended for general acute care use after January 1st, 2030 has some certain deadlines. By January 1 of 2024, that plans for non-structural evaluations for NPC 4 and NPC 5 for each building be submitted to HCI, and those were met. So Mendocino Hospital, Coast Hospital, is compliant with this date. Next date, January 1st of 2026, is to submit to us the construction documents that are ready for review by the office by January 1 of 2028, obtain a building permit to begin construction, and be compliant then by January 1 of 2030. We view this as being very important. This is your service area as we've had it described to us. And the fact is that it's very much oriented to the coast, that passage through the mountains to services in the 101 corridor can be very difficult at certain times of year. So we understand the importance of the hospital to this community. Now, this is the hospital the way we see it at HCI. And what this is called a key plan. Every hospital in the state has one of these, and these key plans are available online. If you were to Google facility detail, it will give you a link to HCI's page that will give you the information that you see here for every hospital in the state. The only difference is this one's colored because I wanted to show you which buildings are currently SPC 2 rated. And it is the main hospital building, which is, again, a single-story wood frame building, and the old central plant building. So these are the two that need to be structurally updated through retrofit. And each one of the seismically distinct buildings has its own identity, its own name, and its own performance rating. As you can see here, you have two buildings that are rated SPC 2. All of the rest of them have conforming ratings. So your focus is just on those two buildings. Also on your NPC, as we noted, you are NPC 2 compliant, which meets your current deadline. But again, the deadline for NPC 3, 4, and 5 is 1/1/2030. So what this tells me is that you're completely conforming at the moment. Now, when you look at the long-term use for these buildings, the main hospital has most of the services. And these are services that were reported to us under Assembly Bill 1882. By January 1st of this year, every hospital was to report to us which services were in which buildings. And you can see here that the majority of the work is in the main hospital. So this building is essential to the overall operation of the hospital. Likewise, the central plant with its SPC 2 rating is the principal source of utility origination. So again, if something were to happen there, it could take the whole hospital down if it were not properly retrofitted. We mentioned the two buildings. The main hospital building is wood. It's commercial, industrial, single story, and the central plant, wood, light frame, single story. These are the simplest buildings to retrofit. Again, and I know in past years I've heard outlandish numbers of the cost of retrofit that had come from this district when I was working with Sutter Health and paying attention to the various facilities in our market. And I didn't believe it then, and I don't believe it now. Quite frankly, these are simple structures to retrofit. Maybe holding the roof down, maybe an additional shear wall. I'll leave that to the structural engineers to define what the scope of that work is. But historically, we see that these really are the best ones to work with. There was mention earlier about the Small and Rural Hospital Relief Program. We heard from the hospital group. And the fact is that this facility is a member of that program right now. The first step in that program was to have an updated seismic compliance plan on file. Senate Bill 1953 required that every hospital have a compliance plan on file with the state by 2001. Most of them have not been updated since 2005, just so you know, and dates came, dates went. So to participate in this program and to be eligible for funding, we did require that every hospital update their seismic compliance plan. This was approved by HCI on December 15th of last year. This was prepared by Devaney Group Architects and with the support of Degenkolb Structural Engineers. I see the principals of both of those on the call here today, so they will be able better to answer technical questions than I would be. And we're going the wrong direction. So what the compliance plan said was that by July 1st, on or about July 1st of this year, we would expect to see submission of a geotechnical report and materials testing and condition assessment concept. Geotechnical report is something that still needs doing, but we understand that the geohazard report that goes with that was done some time ago to help you get your SPC2 rating. So again, you already have some of that work already in place. These are approximate dates, and they were intended to be guidelines rather than absolute. So if you're a little late on something, that's not the end of the world. The retrofit plans, though, you've told us that you expect to submit those plans by September 1 of 2025 and have them approved by March 31st of 2026. Retrofit construction, August 1 of 2027. SPC 4D certification by August 1st of 2029, or I should say September 30th of 2029. So again, the schedule that was given to us was a conforming schedule. The NPC schedule, as I noted before, followed the regulatory dates. So there was no question about that, that you were proposing to compliance. With that, I'd like to shift gears a little bit. We talked about seismic safety and why it's important and what it means to your facility. So as was mentioned earlier, there is funding available from the state to help you advance this program, and it's in the form of the Small Rural Hospital Relief Program. The program provides technical assistance and reimbursement grants to qualified participants actively engaged in seismic improvement efforts. This was created under Senate Bill 395, Caballero, and it provides for 10% of the excise tax revenue collected on the sale of electronic cigarette products. We were a little concerned about that funding source, since that really should be a declining revenue source. People should not be smoking so much. We're a little uncomfortable about the fact that we're being funded by smokers, but the fact is that that's what the legislature thought, and we appreciate the money. So the program is for small hospitals, for rural hospitals, and for critical access hospitals. The mission of the program, of the Small Rural Hospital Relief Program, is to support and enhance the effort of small, rural, and clinical access hospitals to preserve access to general acute care for the communities they serve through provision of state grant funding and technical assistance to advance building seismic safety and resilience. So, Mendocino Coast is a qualified participant now. You have fewer than 50 beds with 25. You have a rural designation, and you are designated as a critical access hospital. So you go right down the line with that. Now, to qualify for grant funding, a hospital must also indicate that seismic compliance imposes a burden that could result in loss of services for a community. And while that says it in the law, I don't think anyone argues that anyone that comes to us is in that position. So we understand that everyone that we're working with is at risk. So how does it work? Hospitals establish eligibility and has a currently approved seismic compliance plan can seek funding for a qualified scope of work. Funding is granted as reimbursement for work completed or in progress. The state cannot give money on spec, pure and simple. Sequential applications for specific phases are allowed, so you can apply for a grant for an early phase and come back later for more. But the money's not the only thing. We also provide seismic technical assistance, and this is where we actually reduce the cost of compliance. So we work with each one of our clients to explain the process, to help identify seismic compliance scope, coordinate and communicate between various parties, provide recommendations on the minimum required seismic scope. For example, material sampling. We have reduced the number of tests for our small rural hospital clients considerably. And an example that I like to use is one of our early participants, and the designers brought to us a materials testing program that would have taken 50-some-odd samples of, yes, 50-some-odd samples of the building, including foundations. And by the time we were done working with them, we showed them how they could get everything they needed with 7 samples and no foundation. So again, the designers aren't wrong. They don't want to get it wrong. But when they come to work with us, we can help them see how little they actually have to do to be able to move this forward. Now, we also provide continued support during the construction phase, plan review phase. We help you with the preparation of your reimbursement grants. And continued support through the entire process. So where are you now? You are in the pre-design phase. This is your next step for you. The retrofit feasibility studies that we talked about back on the schedule, materials testing and condition assessment program and reports, and the NPC-4D and SPC-4D and NPC evaluation reports. So this is really where the money is. A lot of discussion has been made here about Assembly Bill 869 and Dr. Wood's bill. The fact is this is aligned. This actually reflects what had been already approved, and this is the sort of thing that he has talked about putting in the bill for appropriate funding. Help people understand what their problems are before you start trying to fix them. Design phase activities and construction phase are possible as more funds are available. So what is materials testing? Identify and verify properties and conditions of the building. It includes minor construction. It does require a permit to do this. Taking samples of concrete, steel, masonry, and wood from the building, as well as opening up critical locations to observe its current structural condition, so that the designers know exactly what they're getting into. Now, something to understand, we heard in the prior presentation that there may be changes to deadline. I can't discuss that here, pending legislation. But people are aware that the building code changes. Every 3 years, we have what's called a code cycle. And there's been some concern about whether if a hospital were to invest in a materials testing condition assessment program today, would there be a code change come along later that would invalidate it? And the answer is no. Absolutely not. The results are durable. So we are encouraging the district to move forward with the empty cap program with the understanding that you will never get it at a lower cost than you will today, and that the results of that will be good regardless of when you need them in the future. There are things that are not eligible for grant funding. If it's not seismic compliance related, but you want to do it at the same time, we urge you to coordinate that with us so that we can parse out the structural work that would be qualified for the grant from the rest of the work. So we're not paying for operating rooms, we're not paying for MRIs, but if you want to do those things at the same time, it makes a lot of sense because you have the same contractor on site doing 2 scopes of work, and they're only disturbing things once instead of twice. So it is the right time to do the work. So what's next? Right now, our fund balance is $6.2 million. We expect the grants to cover only a percentage of that, but the empty cap projects that we have funded here one for Me Memorial Hospital in King City, one in Kern Valley Healthcare District in Lake Isabella. We were able to grant them roughly 80 to 85 cents on the dollar of their expenditure, which was a tremendous benefit back to them. And in both cases, they said, we're going to take that money and turn around and put it into the next phase of design development. So again, this helps moving things forward. And just this week, we awarded $625,000 to Mad River Community Hospital in Arcata for their NPC 3 improvements. Now, Mad River is in what's known as seismic zone F. It is the riskiest zone in the state, and their NPC 3 work is due now, not by 2030. And so this has helped them move that forward. And this came out to about 45 to 50 cents on the dollar for their work. So again, we were very happy to be able to go that high with construction work. We have been promised another $50 million for the program. We've all seen what's happened with the budget. So we've been a little bit skeptical about this. But again, as we've heard repeatedly, there is desire on the part of the legislature to get this going and going now, with an understanding that the rural hospitals truly need this help. So I have to say at this point, we're simply cautiously optimistic. So that, Mr. Chairman, completes my presentation.
Thank you very much. Let's start with questions from the board. The questions from the board? Board members?
Can I ask?
Yeah. Okay. Director Savage, I saw your hands first. So.
Okay. We've done a number of community meetings just to find out what people need and want in healthcare on the coast. And what I think, at least I've heard at both of the meetings that I've been to, is some lack of clarity on what happens if we don't retrofit the hospital. What are the consequences, and what would that look like if, because of timing, because of money, because of all of the above, that we don't succeed in meeting the deadline? What does that look like?
As it stands right now, the penalties written in law are negligible. They simply say, you're not allowed to operate, period. Now, I don't think people really take that seriously. I can tell you most hospitals don't. Mm-hmm. Having come from the industry myself and having advocated for hospitals, I can tell you that they don't. Okay? But what we're seeing and what you heard in the prior presentation is there is interest in establishing accountabilities for meeting compliance in the future. And again, I can't comment on pending legislation, but I will say that that is a topic that I have heard. So whatever comes next, I suspect may have something in it like that.
So when you say not allowed to operate, that means, what does that mean?
Well, it means you're supposed to surrender the license, and that's what's unrealistic about the current law. That's one of the reasons why it's being pushed so hard now, because that's only 6 years from now. It's just not credible. Mm-hmm. And no one wants to close a hospital. The whole purpose of all of this is to keep them open, to make sure that there is access to care. And that's the name of our department.
Mm-hmm.
Okay. Director-elect McGordy.
I wonder if in all of this legislation, if there's any distinction made between one-story hospitals and, 17-story hospital?
Not really, not that I've heard of. And again, not commenting on legislation, but more the locale rather than the nature of the building. So, the fact that rural hospitals are the ones that are getting the focus as opposed to the size of the building. And what's interestingly enough, the Small and Rural Hospital Relief Program law was written in such a way that a small urban hospital could also get funds.
Could also be what?
Receive funds.
Oh.
So, small hospital. So it's really differentiated on size and locale, and not it's the size of the facility, but not the number of stories.
Okay, thank you.
Well,
Director
somebody
Savage.
else, go ahead.
Go ahead. I don't see anything here, so you're up.
Okay. You mentioned that the funding relief that's out there is reimbursement.
Correct.
And so I'm curious what that looks like. That means that we would have to, if our estimate is $20 million to retrofit, that we would have to be able to come up with that with the expectation possibly of being reimbursed. Is that correct?
Well, that's correct, but the scope of work you described is not. So what we're reimbursing right now is pre-design. The analysis of the
Got it,
building.
Not construction.
Not construction, no. And so when I said 85 cents on the dollar for pre-design, we're going to be lucky to get 15, 20 cents on the dollar for actual construction work. But the thing is that if we've done our job with your design team to reduce your cost going forward, that's where you're going to get your first and most benefit, because it's going to reduce your final cost.
Director Katsif?
To the best of your knowledge, what percentage of the hospitals that fit the category of rural, et cetera, are using a bond issue to raise the funds to do this work?
I don't have that information. I do know that many in this position have gone for federal grants and those kinds of things, FEMA grants. But I'm not aware of the smaller facilities going for bond issues, so I'm sorry, I can't respond.
The reason I asked the question is simply because I'm interested in what other options we have. And somebody should know at HCI what other options there are other than bond issues when you need to raise $10 or $20 million in a low-income community. And you see, you are witness to the way Mr. McDonald had collected a fact sheet about what we're working on, or trying to do with the community or for the community. And so the question of, is a community ready for a $20 million or $30 million bond issue when we haven't even assessed the impact of, let's say, AI on medical care? We don't know the future. So we don't really know exactly at this point what we need, and we haven't done an appraisal or an assessment of what we already have that is, relates to community health that is not the hospital. I mean, the hospital is one piece of community health, but there are many pieces that relate to community health, and we have not even done an assessment of the other therapeutic modalities that exist. So my interest is in trying to figure out, do we have options, and what are they, and who do we speak to if we believe that a bond issue may not pass?
Your timing is interesting. So just today, I saw a request come down from the Health and Human Services Agency for us to assemble precisely that kind of information. And so over the next few weeks, we're going to be doing that. Now, understand that I'm going to continue to be involved with you and with your project team. So we're going to keep you apprised on what we learn as we go. Fact is, I've had the very same questions. It's not just FEMA, it's not just USDA. There's got to be more out there than that. So we're in the process of gathering that information now.
Thank you.
Oh, thank you, because again, we need to cover all of our bases.
Thank you. Now, at this point, seeing no more questions for board members, questions from the public?
There is one online,
Okay.
and that is, please talk about the consequences of failure to submit documents required by HCI at specific timeframes.
It depends on the nature of the submittal. And for the most part, as long as it's not tied to a statutory deadline, then it's not really a problem. In some cases, our regulations require, for example, once you have approved plans, you have to pull a permit within a year. But other than that, there's not really any penalties, again, other than if you're under a deadline that has penalties associated with it. Again, the penalties aren't in place that are necessary to really enforce that, just to be blunt. So that's why there are those kind of discussions going on now.
And maybe a follow-up, if the board doesn't run the bond this year, is there a mechanism in place to change the financing plans that doesn't harm the board?
Yes.
Do you want to talk a little more about that?
Well, yes. The compliance plan dates that we reviewed here are amendable. So again, the compliance plan is a roadmap. It says, in general, here's what we're going to do and when we're going to do it. And well, more often than not, it turns out to be some wishful thinking. That's okay. That's all right. What we're really looking at is the deadline and making sure that you're on track for that.
And then it says, to date, the district has spent thousands of dollars on the pre-design phase. How much of this cost is likely to be reimbursable?
That's a good question. We would have to see what the scope of that was. Some of it, when it's purely conceptual planning, things that, for example, could not be amortized, for example, those things get written off. But if it's anything that is durable and is directly associated with seismic work, we would like to talk to you about that in your grant application. So where we are in that process, you're in the program now. We do not have a grant application on file from you. We'll work with you to prepare one of those. In that, we'll define the scope of work that you're looking for and seeking reimbursement for, and validating then that it is something that would be qualified for reimbursement.
Would you like me to read
Yeah,
these?
go ahead. Let's
Okay.
go on to the.
So a question from the audience, are VA clinics and hospitals subject to HCI requirements?
Those are federal government, and they sit on federal land. They do not require state licenses. So this is a state of California initiative only.
Okay. Looking at this project from a cost, risk, benefit standpoint, there's a couple questions here. One, what Richter scale number earthquake will the hospital be able to currently survive? And what Richter scale number improvement will the seismic retrofitting offer?
Ooh, good question.
My apologies to the person asking the question. I'm not a structural engineer. I'm not qualified to answer that.
Okay.
I'm sorry.
We do have some on the line who may be able to answer that later on in the meeting.
Very well.
A second question there, what is the likelihood, according to geologists who study earthquakes, of an earthquake happening between these two specific Richter scale numbers? One local geologist has predicted a very low probability of any serious earthquake happening in Fort Bragg due to the relatively short time earthquake-wise since the last big one of 1906, and the nature of the San Andreas Fault here off the coast, which slides into the three-fault junction off the Eureka coast.
And we made that point earlier in showing that your seismic risk was relatively low compared to the county to the north, higher than, say, the Central Valley.
And then what level of damaged yet still able to function would be possible with an earthquake occurring in this proposed new Richter number retrofitted range?
Again, without knowing what the modeling of the building is and how it would behave in that earthquake, I wouldn't be able to speculate.
Okay.
I just wanted to comment on these questions, if I may.
No, let's. I think-
Get into your mic if you're gonna.
Well, I've got to get
Go ahead.
approval
Go
first.
ahead. Go ahead. Take the floor. Go ahead.
It seems like those three questions, or four, are all about cost-benefit analysis. Basically, what's it going to cost and what's the risk? And I wonder how many people in the community are concerned with stuff like, should we take the risk, based upon the potential that we may not have an earthquake. I think the questions are really important, but I wouldn't know how to deal with, as a board member, with an answer to that. I think that's basically asking us to take the path of least resistance, and I'm not sure that as a responsible board member, that I could do that. So I wonder what other communities, how other communities would answer those kinds of cost-benefit analysis questions. And if you know any.
No, it's difficult, and again, we don't get into the cost so much at HCI. We're looking more at the technical side of things, so I really can't address that. But think about this. Let's say that you were damaged in such a way so that your operating rooms were out of service for 2 years. What would be the viability of the hospital? One of the things that I hate spending money on the most is insurance. I hate it. To me, it's just money down a rat hole. I never see a benefit from it, but you know something? If I didn't have it, that's when it would happen.
If you didn't have it, you have a nervous breakdown. And that's, so that's why it's so important to have a hospital, because it underlies all of our stress levels. It raises the stress if you don't have it, and it lowers stress if you do have a hospital. And lower stress is better for health.
Agreed.
And I'm struggling a little with handwriting here. I think it.
Kathy, I mean, I can say it.
Go ahead, go ahead.
You want me to do it here or go up there?
Just from right there, go. Yeah, he's got the podium.
First of all, preface, notice that Mr. Garza said we're taking the extraordinary action to allow public questions. And we weren't allowed to ask public questions for the previous presentation. This, my comment and question here that.
Can we stick to the questions, please? Okay, then.
I'm sorry that you don't like to hear reality.
I'm not interested in having a discussion about this with you,
You're
Mr.
starting-
McDonald. I'm trying to be respectful of the time. We've got other people who have questions, so please ask your
Barely
question.
half of the back and the front of the card, so. Last night, I had a conversation with a statewide Adventist health official, and I asked that person, where's Adventist Health at now? RE retrofitting its hospitals? Are you still banking on the legislature to push the time frame back or change seismic laws? The response was any legislature would push back to 2037. And even then, probably just the emergency rooms. As an example, the largest hospital in Fresno, text abbreviation, so they have 1,000
Where
beds.
is your question? To question Mr. McDonald.
Why are
Question.
you interrupting me when I'm getting to the question?
I'm.
Come on!
No, I'm sorry, I've asked you twice now. Ask your question.
You're making
There
a
are
mistake.
things that lead up to a question, sir. Do you understand that? Do you?
Mr. McDonald, I understand perfectly well. What I'm trying to do is be respectful of the other people who want to ask their questions. So would you
Come on,
please
stop with
ask
the
your
slick,
question?
smooth stuff that could fill a barn with manure.
Let it go.
Your
Question, please.
That hospital has about 1,000 beds. 90% of it doesn't meet the 2030 standards. The AH official said that hospital can't close, and they have no money for seismic. In conclusion, the official said, we believe it will be pushed back as far too many hospitals aren't to the 2030 standards. It simply isn't possible or reasonable to expect. My question at the end is, how does this relate then on an on-the-ground realistic level and financial level? What is HCI going to do when it's 2030 and the legislature hasn't acted, or it's even 2037 and Fresno still has a minimal amount of power?
Understood. And again, I can't comment on pending legislation, but I will say this, and I think we heard this from our representatives from the Hospital Association as well. This is the year that it's going to get addressed in legislation, one way or another. The fact that the compliance deadline is only 6 years away and the clock is ticking and everyone knows what the risks are, and the fact that there is so much ambiguity on the back end, that the decision makers in the state really want to try to nail this down once and for all. That's what we're hearing.
Okay, thank you. We have another question, I believe, online.
No. I don't see any other question. Does somebody have a hand raised?
Yeah, there's right there. If Lee Finney has a question.
She already asked that one.
Okay, we did address that one.
Yes, that was the first question that was brought up, that Kathy read out loud.
Okay, okay. Any more questions online?
We do not have any other questions online or hands raised.
Okay, so now, Ms. Sally, is it correct that I now need to go to public comment?
You're in public comment now. So these questions are the public's comment. Just ensuring, like you did, you just allowed for the public written comment. I announced that there's no hands raised, so there's no one here online that wants to speak, but I would definitely give an opportunity to those who are there present. If there are any other additional comments or opportunity for those that have not spoken yet to be able to speak and ask questions or inquire to the presenter.
Okay, last opportunity. Okay, well, thank you, Mrs. Sherman, very much
for this
your
opportunity.
presentation, your presence. I want you to know that he came up, as I understand it, yesterday from Sacramento because he and his wife enjoy being in Fort Bragg, and they like to come here they regard it as one of their favorite vacation locations. So we were very pleased to have him here. Thank you.
It was not a challenge to respond.
Yes.
Short comment, Mayor.
Okay, go up to if you go to the podium, Mr. Childs.
Just an interesting comment that I just realized. The cost of this is $20 million. There's 20,000 people approximately on the coast. To do this retrofit, if it goes forward, if it's necessary, if it's wise, if it makes sense, if it fits in, if it's going to be cost effective, yada, data, data, the cost per person on the coast is $1,000 each. $20 million divided by 20,000 population.
Okay, thank you. Okay, now I'd like to turn it over to our Vice Chair, Director Katzeff, for his report on his Planning Committee.
Thank you. By the way, it's maybe $1,000 per person, but it's only land. It's real estate. It's a property tax on landowners or homeowners. So it gets it's a little different way of accumulating the money in a little smaller population than the 20,000. But that's just a comment. So. The Long Range Planning Committee is part of the responsibility of the Vice Chair, myself. I didn't seek this. I was a rookie when I came on. I didn't know much about healthcare, but I've learned a lot in the last 17 months. And one of the things I've learned is that I support the hospital retrofit 110%, which is not where I came to from my beginnings. I understand now, so I'm talking about my learning experience because that's a preamble to my report, to give you a sense of where I'm coming from as a person and what I bring to this table. Because all this retrofit stuff is very boring to me. And I find it really difficult to keep up with all the legislative rules and regulations. But I want to say, as a board member, that I am 100% behind everything that is going on relative to saving this hospital and keeping us in compliance. That said, the hospital is just but one part of the community health. It's one model that we have, that we must have. It repairs people that are broken. It gives us an opportunity to feel more secure if we break an arm, or if somebody from a tourist comes here and sees that there's a hospital, there's a sense of safety. It's good for our economy, not only internally with the 300 employees spending their money in town, but also for the tourist economy, which is part of our way of life. it would be much more difficult for people, families to come here if they knew that they were so far away from emergency care. So that said, there are other modalities, therapeutic modalities in the community, and I've been sort of focusing on community health as opposed to what happens in a hospital. Community health has many other kinds of therapies. There's psychedelic therapies, there's cannabis therapies, there's herbal therapies, there's spiritual therapies, there's all, and we have not inventoried those therapies yet. Although on the first day of my serving on this board, at the first meeting, I said we must inventory what our assets are. Because when we know what our assets are, we know what we need, what's missing. We also have the ability to ask the community what they need to see if we have the asset to refer them to. So community health has been my sense of purpose for being on this board. And I noticed in the last presentation that there were three things that were important to HCI, or to our presenter who presented HCI's modus operandi, if I can say that. The three things that were needed after an event, we call them events. They're not musical events, but they're events. Three things that were needed after the event: fuels, water, and sewage. Well, something else is missing from that analysis of what's needing after the event. And that's one of my latest and important interests, and that is food. People need to eat, and we know from some kind of analysis that's been floating around the community for probably 30 or 40 years, is that we have about 2 or 3%, or 2 or 3 days worth of food on the coast if an event happens and takes down our bridges and makes us an island. And food insecurity is, so therefore, food insecurity is not just about poor people not getting 3 meals a day. It's about all people not getting any food every day. And it's interesting to me that in 1976, I had been here 4 years. And in 1976, I saw a need. And I wrote a proposal to North Coast Opportunities to, and by the way, this is about planning. I'm sorry if I'm going off on a long tangent, but I want to explain to you where this project that I'm going to talk to you about came from. So I sent this proposal to North Coast Opportunities, and it was a proposal which they declined to fund, but it was for a community cannery. Now, in our minutes, there is a report on the meeting that was held on whatever date, a couple of weeks ago. There it is, May 9th, and so there's what would I call this? What would we call this? A report of the meeting?
Minutes.
The minutes of the meeting, yes. And in it, there are many things that we talked about. One of the things that we did talk about was a community cannery. Why a community cannery? Because I've been promoting and thinking about this for 50 years. And when I first considered this as a good idea for this community, the people and the institutions that could make this work were not here. And about every decade or so, the institutions change, the people change who are producing food, who are shopping in the farmers market. All things change. And in the last decade, I've And especially since after COVID, when we saw, or during COVID, when we saw the shelves go dry and people were freaked out about, I mean, we don't grow toilet paper here, but, you know, everybody was freaked out about not having enough food. People were buying tons of rice. I mean, okay, so we don't have food storage here. Not only do we not have food storage, but we don't have a way to process the food that we already grow and store it. And we're not talking just about the jars, the glass jars. We're talking about dehydration and freezing. So I presented the idea of a community cannery to this new board that I wound up being on, much to my surprise, and bringing together an idea that applies to us and our community health. And lo and behold, the chairman made me chairman of the ad hoc committee on blue zones. And lo and behold, Judy Leach said, hey, we're doing that kind of work too at Adventist Health. Let's work together. And she gave me her last copy of the National Geographic magazine that talks all about the blue zones. One of the most important things in the blue zone concept of community health is nutrition and food. So it all comes together, and that's what we talked about at the Long Range Planning Committee meeting. Now, funding is needed, but also a catalyst is needed, something, the spark that starts the process, which has been missing for 50 years. I'm the spark, but I'm on this board. So I can't go to work as an employee of the system. So what I was proposing to this board, and what I've been educating this board about for the last 15 months, is that community health is part of our responsibility. And this is a good way to show the community that we are activists, that we are proactive, that we are involved in doing things, not just talking about legislation, not just being a bunch of progressives talking to ourselves about all these wonderful things that we want to do. We got to do something. Let's prove that we have the guts to do something. Now, there has always been a problem with how much money do we have, and how can we spend it, and what are we allowed to spend it on? And then things began to come together financially. For the first 15 months, we didn't know how much money we had, so we couldn't do any planning. Now, under the leadership of these two people, and some of the work that our board member Sarah Spring has done, we have discovered how much money we have and what is dedicated to the hospital needs, mandated and dedicated, and what is not. What is available to spend to help the community grow and improve its community health. And there are funds now that we have identified. Comes from, like, all of a sudden we're getting interest on multi-million dollars. And that interest has not been taxpayer money, it's interest on taxpayer money, and it's not dedicated to the hospital. We may dedicate some of it to the hospital, but there's a possibility of dedicating a beginning point for a community cannery, which is really what's needed is a consultant from the food community in our community to begin the process of searching out the legal, the requirements, the research, the grants, and beginning the process, which is a project that will take time. Now, you'll read in the minutes that Jim Hurst was the first to comment on this. He said, absolutely, I'm on the, you can read it here, I'm on the Harbor Commission, and the fishermen need a cannery, Now, he was talking about a commercial cannery. And there's a big commercial cannery like you can imagine on Cannery Row. And the fishermen do need it. But that's not a health and wellness cannery. That's a commercial economic development cannery. What I'm talking about is a community cannery that is cooperatively run, membership organized from the bottom up, over time, starting small and growing our community into our community health care system. So that was a big part of the meeting that the Long Range Planning Committee meeting that we had. We spent a lot of time talking about it. There was a lot of support from the food community. That people were there from, there were growers, there were seed savers, there were all kinds of, there was a positive response to this need. And that's what I'm working on. That's what I've brought to this board. And now we have to figure out how to do this appropriately, how to spend the community's money to build an institution that will be around for the next 50 to 100 years, if we're around, if this community's around for that long. There used to be, just a little piece of background, there used to be 3, I think there were canneries for peas or beans on the coast, a long time ago. Do you remember that, any of that, Malcolm? So, and in the 1940s, during World War II, there were 400 community canneries in the United States that were funded by Ball Jar Company. So there is, and currently there is a movement around the country to build these kinds of food-related, blue zone-related, healthcare community-related canneries to make sure that the food we grow is the food we eat. That's my report. I can go on and talk about this for hours, and I've actually almost spent that much time. I apologize. I just want to say it's going to take time, it's going to take work, and it's going to take not a board, but a staff. And this board has the opportunity to buy the first staff person to create a new institution in this community. And I'm hoping that I will be able to convince this board to pony up some money for 6 months so we can do the initial work. And I'm open for questions.
Director Savage?
I'm curious, just because it was Mr. Hurst's comment about that they're currently in the process of writing this economic development grant. In your opinion, are those two things completely mutually exclusive, or is there some possibility for cooperatively working on what this might look like as a commercial venture versus also a community one?
I think that that there's a real, I mean, I've been down in the harbor for 50 years.
Yeah.
And it's a strong community. And if you want to give a community cannery over, the land, we're talking about the ocean and the sea, and we're talking about the land. Mm-hmm. And these two things create not an incompatibility, but a whole different mind think. And when you're thinking about a boat coming in with 30,000 pounds of albacore, there is no way that a community cannery built from the ground up by the community, which has members and all kinds of, and gardens and farms, and health as a priority, probably, knowing this community, it'll all be organic. They seem to be incompatible to me. However, you never know, but you don't start by bringing a non-entity into a multi-million-dollar operation. I mean, the incompatibility will happen with people and ideas, not with the final result, which will both look totally different. So Jim was rather strong in his desire to cooperate and work with us. I think I can represent our ideas, if they become our ideas, in a way that would protect them from being overrun by a commercial venture that was highly commercial and really needed lots of size to deal with, with big numbers of big poundage. I think it's a hard mix, but I think there'll be a lot of fishermen who'll come to us and say, hey, I want my fish canned in an organic facility by the community. And there'll be people who will be seeing a smaller operation is more personal. I think they're compatible if they exist side by side. I don't think they're compatible if they exist internally together. But I believe in from the bottom up. So who am I to say? If we get a group of people together who can think these things through and do the research, who knows what the answer may be.
Okay, other questions from the board? Okay, thank you very much. As you can see, yes.
I have a question.
Director-elect McGordy.
Sorry. Yeah, my question is regarding the deadlines looming over the hospital. Is the planning committee looking at that?
Yeah. That's such a broad question, and we looked at the meeting, the last meeting, we looked at what our obligations were and what stood in our way. We haven't had a meeting yet to discuss the future, what the needs are of the future. I think I addressed that in the beginning of my somewhat report, my rambling report. We need to have a big discussion about what the needs of the future are going to be. I mean, we can't make the assumption that the only need is going to be seismic retrofit.
No, but that's kind of the thing that's...
Well, we have to learn to multitask our ideas and think simultaneously about the future and the present, in my estimation. But the planning committee will meet again and talk about other issues. I'm certain we'll have lots of time.
So then I have another question. I know that UC Cooperative Extension has specialists in food.
Yep,
Have you
UC
spoken
Davis,
with-
I've been there.
what's that?
Yeah, UC Davis has,
University Cooperative Extension.
yeah.
It's out of Davis, but
Mm.
they have an individual that serves Sonoma Lake County of Mendocino. Have you talked to?
I have not talked to anybody. That's a staff responsibility, and we have no staff right now. So one of the things that happened to this group for a year was that the board tried to do the staff's work, and I refused to do staff work. We're here to do policy, planning, and oversight. So I haven't gone out into the community in advance of the people that are really going to be the heart of this project. It's up, they got to go do it.
Thank you.
Director Ketchum, would it be fair to say that also that we have learned a lot more about the maintenance requirements or the needed maintenance? The maintenance has been deferred to the hospital from Adventist Health, and we've asked them to put together a plan that would include priorities, dates, and all of that, so that we can look at that, hopefully, perhaps even at our next board meeting, and get to work on making sure that the basic needs of that, the maintenance of the facility are now get fulfilled. Is that fair?
Absolutely.
Okay.
It was the first part of the meeting. It was not, my co-chair is the chair of the board, And so when I saw that when we decided that was going to be part of the meeting and the discussion, I asked Paul to bring that to the community, that discussion. Yeah, it's really important that we have the ability to plan these expenditures that the hospital needs. And we had a big list, a giant list, and we have an obligation to that list, but we didn't have timelines for each one. We had dollar amounts, but we didn't have timelines. So we've asked Adventist Health to give us timelines and priorities, and that's coming. I hope, one other thing, I hope that we have the opportunity to do a community assessment of needs. I think one of the most important things that is coming down the pike is this meeting at Town Hall on the 30th. And I think that it's really critical that the people here should be there. It discusses.
Oh, are you going to take public comments on his report?
No, this is just receive only. Okay.
I'll leave it
Okay,
at
thank
that.
you. Let's, if there are no more questions from the board, let's move on to the agenda. We're now at consent calendar. You have a number of items on the consent calendar. Does the board members want to pull any item of the consent
You
calendar?
skipped Kathy's report.
Yeah,
Oh, I'm sorry.
It's okay, I'll just be
My-
very-
No, my apologies. Miss Wiley.
thank you. Very briefly.
Director Spring.
On the May 30th Town Hall, just to reiterate, it's at 6 PM at Fort Bragg Town Hall. There will be practitioners, including Dr. William Miller and Jessica Rose Curl, an acupuncturist. We have Ron Nadeau giving an invocation at the beginning, and there will be some of the authors of the study from Humboldt will be in the room. So I encourage you to attend that, and that will be Zoom live streamed. And then I'm also working on continuing the work on developing policies and a bylaws update that's over a year old now, and hope to bring those to the June meeting, the bylaws. And then I wanted to remind the board that the planning committee meeting is scheduled for June 6th at 1 o'clock. The finance committee meeting is scheduled for June 20th at 1 o'clock, and the next regular board meeting is June 27th at 6 PM here in this room.
Okay,
Through the chair.
Through the chair.
thank you.
This is our ongoing dilemma with the Brown Act. In terms of our attendance as board members at the forum on the 30th, what are the rules and regs, and what can we do? Or does that mean that only two of us can go to this thing? Or what's the
No,
rules?
I can't imagine, we're not discussing anything that we're going to talk about here for vote. It's a forum to talk about health, and I think the most general
Well,
way.
I'm just checking to make sure.
Yeah, I believe it would
And
be.
we have our lady on the screen.
And I hope all of our board members are there. I would miss you all.
As long as we don't talk about board business.
It's
Okay, I'm-
similar to a workshop where everybody gets to go and hear what the presenter has to say, but you're not conducting board business.
Okay.
Okay,
Thank you.
interesting question. Okay,
Oops.
since I'm below our sequence, Director
Can we
Savage.
take a 5-minute break, please?
Pardon?
Can we take a 5-minute break, please?
Yes, absolutely. Let's recess for 5 minutes and come back to order approximately 5 minutes to 8.
Thank you.
Okay.
Recording in progress.
Okay. So now the item for consideration is consent calendar. Okay, do board members have any item they would like to pull?
I would like to pull 4G, please.
Okay, 4G is pulled. Anything else? Okay, now, if I understand this correctly, Miss Alley, I can,
Approve everything else.
we can move to approve the other items on the consent calendar and then move on to our discussion of 4G, is that correct?
That is correct. I would recommend that you ask the public if they have any items that they want to speak on, or give them the opportunity to speak on items 4A through 4F.
Okay, that's fair. Are there anyone who want to speak on items 4A through 4F?
Does this include the pulled item?
No,
No.
4A through 4F, yeah.
We will get an opportunity then.
Right, exactly. Right, okay.
Okay, hold on, hold on.
Hearing that, may I entertain a motion from Director Savage?
I don't know that if it needs to be pulled, but I noticed that there was what may have been just a typo kind of thing in one of the minutes where, I mean, bless your heart, Mr. Katzif, but apparently you were noted as chair
Of what?
of that the meeting was adjourned. And I'm looking to find which one it was.
What are you doing?
I think-
Well, he
In
did-
the minutes of one of the meetings, it was,
He was the chair of the standing.
no, not
Okay.
of the standing one, it was in one of the other minutes. Because I believe you might have made the motion. But anyway, that kind of minor editorial thing, I didn't think we needed to pull it in order to make any correction like that, and am I correct about that?
Yeah, that's a scrivener's error. So Secretary, you are right, and it is very much appreciated that you found that and looked through that. Before we sign these minutes, we'll make sure to do a double check on that.
Okay, good.
But it's a scrivener's error that can be corrected, does not require an amendment for correction within the motion. So excellent, thank you very much.
Okay, so can I have a motion to approve items 4A through 4E, or 4F, excuse me, on the consent calendar?
I make a motion to approve items 4A through 4F on the consent calendar.
Thank you. Is there a second?
I'll second that.
A second by Director Katzif. Okay. Can we roll call vote, please?
Are you ready? Okay. Paul Katzif,
Aye.
Susan Savage, yes. Sarah Spring,
Yes.
Paul Garza,
Yes? And the item is approved? Okay. Okay, let's go on then to 4G. Let's first go to board comments. Board members have any comments on 4G? Okay, hearing none, public
Well,
comments?
no.
Oh, okay. Director Savage.
So, A, daily, I feel is an overkill for an organization such as ours. And also, generally, when cash is dealt with, which the likelihood of us dealing with cash is slim to none, usually there's a double count of cash physically before taking it to a bank. Do you want me to go item by item, or how do you, would the? you like-
It's whatever you prefer to do. Just take us through your concerns.
Okay. And then on 4D, I had a question, what about items such as Mendocino, where the board has already approved that they will be paid without going back to approval from the board of directors?
Well, I think since we've taken that action, that all it's saying that's got to be approved by the board of directors, we've approved it, right?
I just want to make sure that it's not
That's-
a double approval.
No, I would hope not, but,
And then on E, where it says every check greater, I would think it needs to say every check or electronic transaction.
okay. Every transaction.
Electronic transaction.
I got
Okay.
it.
Or electronic.
And then H, I don't think that we should have the chair be responsible for authorizing everything. I think that power needs to go to the full board and not one individual. Same with I, where it says prior consent of the chair, it should say board.
What item are you on again? I?
Aye.
I. It's about middle sentence, middle page.
I got it.
Okay.
And then on the other page 4, near the bottom where it's talking about request of transfers having one of the 3, I think that it should be 2 of the 3 because then a dollar amount will probably be above one person's authority. And then 6, same thing. It
Well,
should-
we would have to, the CFO, that would be the first set of eyes on it, then the chair, secretary, or the treasurer would have to approve it.
I think it should be 2 board members.
Which item are you on?
That was 4. Instead of 1 board member, I think 2 board members should be doing it. And then item 6, same thing, 2 board members, not 1. And then on item 9,
I believe the way that's written, that would be all 3 would have to agree. And maybe I'm not, maybe I'm reading it more differently than you are.
Yeah, I don't see the 1 out of 3 on 6.
I read it the other way, that it would be 1 person,
Yeah,
not all 3.
all 3 would be required.
So then, maybe you need a word
Yeah.
of all in,
Of all, but yeah, then I think that would make more sense.
Or put the word "and" instead of 3, so that the approval of the board chair, the board secretary, and treasurer.
yeah,
Right.
that would work.
And then 9, I think instead of quarterly, it should be monthly.
Okay?
And then 10, where is the policy that's the district settlement policy?
Is there a policy?
There is
No,
not.
we
Through
do-
the chair, there's not a
we
policy at
don't-
this time, and this policy was lifted verbatim from CSDA sample policy.
And we can retain that, even though we don't have a policy as yet, knowing that we're going to develop a policy for that. And we're just saying we'll be guided by that policy when we develop it.
So the district's policy for settlement to be determined?
Well,
To
it-
be determined.
Well, it shows that you don't have one now.
I'm sorry?
To be determined shows you don't have a policy currently.
I guess, yeah, we could do that, sure.
Or you could strike
do we
that
pull
one.
it?
You could strike number 10 for
Or just
now.
take it out.
We could, that's the other alternative, yeah.
Yeah.
That's better.
Okay.
That's
Any
it.
other comments from the board members? Okay, hearing none of public comment, I'm sure Mr. McDonald wants to be recognized.
So I agree with all of the comments that were already brought up by Director Spring. And I would note that most of those comments are similar to what was brought up the first time this came. And I think I pointed out then that it looked like it was a boilerplate from somewhere else because of the language. And so the point of that is that then nobody went back through here and made any changes. To me, that's on staff. Sorry, but it is. I think that Kathy's doing some good things on, many other areas, but this is an important document. I don't think it should have been in the consent calendar either time.
It's
I
the
mean, this time.
responsibility, actually, of the policy ad hoc to make those changes. It's not a staff function.
Thank you. I definitely think that the places where it says chair, like in 1H and I, that has to just be the board, H should read, the board of directors shall be responsible, et cetera. And I in the middle should be the prior consent of the board of directors. It's just way too much. I don't care whether it's Paul Garza or Lee Finney or Jessica Grinberg or Sean Hogan or past presidents and chairs I'm naming. I would have the same view and have voiced it about similar things. I do agree with you that I think maybe it was Jan who said put and in there, or maybe it was Susan, one of the two, on 4 and 6. That will work. I don't think that you can be relying on a policy that, this is about number 10, that you can be relying on a policy that hasn't already been put before the board and been voted into action. That's just irresponsible to do. To me, what's obvious and a myriad number of reasons. And the main reason I'm up here is because it was all brought out before, or 90% of this, and then nothing was done about it. So.
But we decided last time that it was the first reading, so we brought it back for a second, and that's where we are now.
Well, somebody created it, apparently this ad hoc, and maybe that ad hoc should have met between then and now.
We did.
Yeah, that's my point. Nothing was changed.
Okay, any more public comment? Anything from those online?
We do not have any hands raised online.
Okay. Okay, thank you. So let's go back now to board discussion more fully, as we've heard from public comments. Director Savage.
Just in terms of process and procedure, what is the easiest, most expeditious way to address the changes that Sarah has suggested? Do we do those one at a time? Does she make a motion to adopt all of the above? How would you like to proceed?
Chair?
You have a suggestion,
I
Ms.
do.
Wiley?
I think that we can go back and memorialize exactly the correct language, and you could have a motion that adopts with the corrected language on the floor.
At this meeting or the next one?
No, at this meeting, we actually need this internal control in place, and we've kicked it twice down the road if we don't act on it today. And Norma and I can go back and get the exact verbiage, and the motion could be, again, except with the revisions that were discussed.
Are board members comfortable with that?
I'm not.
Okay, so let's go through it again. And let me make sure I understand the changes that have been made. The first change is in item E, is that correct? Or was there something before that? A, okay. Will we prepared, what was the change there?
I think daily is overkill.
So what, weekly? Monthly?
I think weekly is,
Weekly.
but it's going to be prepared and given to who also?
This would be prepared and under the direction of the CFO.
So what about when we don't have a CFO?
Well, I guess then we'd have to modify our policy at that point.
Because it doesn't say to give it to the CFO, I guess,
Well, I would say, let's say it. We gotta have a CFO going forward forever, because there's a big business with millions of dollars coming in and going out. And we have to have a CFO. Otherwise we got our head up our butt.
Yeah, essentially, the way this would work right now is that Ms. Wiley would be responsible for the receipt, providing the receipt of all logs, cash and received, all checks, cash checks received, period, excuse me. And that way, it would not be done by someone in the finance department, which would be our CFO.
Will be prepared by,
We make it weekly, we could make it bi-weekly, you could make it monthly. What is the will of my colleagues here? Director Savage?
Well, I guess my question is, and I think it just got said, to be submitted to who? On the one hand, a receipt log of all cash checks received will be prepared, one could argue, monthly for presentation to the board.
yeah.
That, given our current configuration, kind of makes sense to me.
Okay,
But
so
a
monthly.
weekly, daily, anything else,
Okay.
I don't
Yeah,
know
this
what
is,
to do.
you know, clearly the policy is designed for people who have a lot more financial activity than we do. Yeah, okay.
well, and a lot more pieces to their structure than we do.
Okay.
So I
Okay.
don't know if something like that could be prepared monthly for
Okay, so,
presentation to the board.
Let me
If
see if
that satisfies what the purpose of this line is.
Yeah. Let me see if this works for you. A receipt log of all cash checks received will be prepared monthly for the Board of Directors by an employee or consultant not in the Finance Department.
Yes.
That work?
So I
Yes.
want to ask a question. Why not in the finance department? What's going on here?
Two eyes, the idea of having two sets of eyes on it, a separation of that, so that if one person has all control, it's easy to, you have a risk of someone manipulating the records and making it hard for us to discover what's going on.
She also said that to double count cash, do you think that needs to be in there too?
We don't
We
deal
don't
with
receive-
cash,
we don't
but,
receive
but
cash.
if we did, I think I don't know if we're gonna be, I know that that's what auditors like to see, is that cash is double counted.
We have three sources of revenue currently. The first is the base taxes. The second are funds from taxes coming from the 216 bond and then also Measure C, so this is the second source. And the third is rent from Adventist Health. That's our revenue. So I'm not aware of us at this point receiving any cash. So how does that work for you? Prepared monthly for the Board of Directors by an employee or consultant not in the Finance Department.
So the consultant would be Kathy?
Realistically, at this point in time, that would be Kathy.
It's just keeping a log.
Yeah.
Did the treasurer doesn't do anything? The treasurer of the board doesn't do this?
The treasurer of the board could do this, yes.
Oh.
The problem has been, through the chair,
Yes, go ahead.
the problem has been that the officers have had to act as staff members because there was not staff.
And that was, and board members took on a whole lot of work, and to their credit, because
Absolutely.
it's tough. It's tough. It's hard to get all of this done and fit into your schedules, way beyond the normal expectations. But fortunately, we've got some staff now. And Susan's showing how much energy she was consumed by all that work she had to do. Okay. Okay, are we okay with with A now?
I would have to say, as the current treasurer, I would think that if there is a check, the treasurer should know about it before the board meeting.
Okay, and we can say monthly for the board with a notice to the treasurer in advance. Is that acceptable?
Upon receipt.
Well, we're just doing it monthly, so, but that you would get it
But
before.
if a check comes in, I think the treasurer should know that the check came in.
Okay, well, you wanted this to be monthly. Would you like this to be
No, that's
weekly?
the monthly report to the board.
It's different, it's a different topic. I mean, it's a different part of this. I think that what you're worried about is one person having all the control. There's no difference between the treasurer doing the work and having all the control as there is to having a staff member doing all the work and having all the control.
The idea here is that they're not, the reason why it's the CFO is not doing this is because then you have two people involved in it, and you don't have one. Is that clear? Yeah. So it's, Director Savage, you have a solution?
Well, it sounds like to me that there's two separate issues here. One of them is this receipt, and maybe possibly a second concept, and maybe to be added, is who gets notified when checks or cash are received.
Okay, so we can add
Is
here,
that-
if you're okay with the monthly receipt of all cash logs received will be prepared and submitted monthly, then we can add the line, treasurer will be notified,
Upon receipt.
let's say within, I'm thinking if we got something on a Friday,
Here.
Monday, so within 72 hours, would that be reasonable?
So I have an idea.
Okay,
So all cash checks received will be reported to the board treasurer, and a receipt log will be prepared monthly for the board of directors by an employee or consultant on the finance department.
how's that sound, everyone? Thank you.
Is that okay?
That works.
Okay, okay, let's go on then. Now we're on to E, is that correct?
D.
D.
Well, I don't know. You talked about pre-approved vendors. Does that need to be in there?
I just was clarifying, so I want everybody to agree that if Kathy is to pay a bill, or I'm to pay a bill, such as Mendo Litho, because the board has already approved that that can be paid without being on the warrant list, that that's still the case with this policy.
Yeah, I believe that would be correct, because we made a kind of a purposeful and intentional deviation from what we normally do there, because we want to support our small businesses. We don't want to run them into the ground. Yeah, and so I think that's still our intent.
Okay, so then it would be E, it would be next.
Okay, so then every check or electronic transfer?
Transaction?
Transaction.
Okay, thank you. Thank you. Okay. Does that satisfy everyone at this point? Okay, so then let's go on then.
H.
Okay, you took better notes than I did. There was a lot going on. Go ahead. Why don't you please?
So H, the board of directors shall be responsible for authorizing all expenses and encumbrances.
Okay, that's fine. Okay,
And then,
Chair,
yes.
that H comports with what your bylaws say.
Yeah, I realize that.
what, having the chair
That
there?
the chair is has the ultimate responsibility for the finances of the board of directors. And that's almost verbatim.
But point of information, because that was discussed when we were talking about amending the bylaws, and there were a number of places where, in discussion with the bylaws, that we may choose to amend what the bylaw says as well to be more in compliance, assuming that this is the will of the body, to not have all ultimate authority resting with the chair, that the ultimate authority really is the board, then that's part of the discussion to have on the bylaws as well.
And if I remember correctly, Paul, is it okay if I speak? Paul?
I'm sorry, what?
Is it okay if I speak?
Of course, yes, please.
If I remember correctly, some of the stuff that we've already gone through, the revised, not approved, was to take that ultimate power and give it to the full board and not the chair.
I believe so, but I'm talking
no,
off the
it's-
top of my head, and
no,
again,
it's,
we're going to have a bylaws discussion
Yeah.
when we resurrect that long-awaited draft way back when.
Let's-
But I know that discussion did take place when we were in the process, and so if it doesn't reflect it, it certainly can.
Yeah, I think it's best if we not get into the bylaws discussion this evening. If you're comfortable with saying the board of directors shall be responsible, let's move on,
Okay.
okay?
And then I, without the prior consent of the board instead of just chair.
Okay. Okay. And where are we now? Your notes are much better than
You're on
mine.
number 4.
Okay,
Number 4 was, we already fixed that.
2, okay.
2 of the 3.
Okay, and then,
Number 6, we put in the word "and," so that all those people had to.
and treasurer, okay?
And then number 9, we got that monthly.
Right, okay,
And number 10 is,
eliminated, okay.
and number 11
That was okay,
is now number 10, right?
right.
Right.
yeah.
Yes.
This is, 11 becomes 10.
Right.
Okay,
Is that
okay,
okay?
Yeah.
okay. Okay, so we need a motion for approval of these internal controls as revised.
I make a motion to approve the internal controls policy number 3 as revised.
Okay, is there a second?
I'll second.
Okay. Okay, any comments from the board? Okay, hearing none, call the question. Roll call, please, Director Savage.
Okay, Sarah Spring,
Yes.
Paul Garza,
Yes?
Paul Katzif,
Yes.
and Susan Savage, yes.
Okay, thank you.
Policies approved.
Let's go on to our regular calendar. First is a receive and file, but a very important one. Mr. Allen, your financial report.
Thank you, Mr. Chair. I'd like to begin with pointing out that I believe this single-page document is a foundation from which I think people can understand, they can believe in it, and they can commit to support it. So, very important document. Essentially, it is divided into 3 parts. Where do the dollars come from? Where do the dollars go? And what dollars remain to kind of maintain the hospital and to assure access to modernizing healthcare on the coast? So let me get started into the detail. I just heard you talk about what the 3 sources of cash are, and you cited it correctly. They deal with Measure C. I would point out that it expires on this document, let me start. On this document, it's merely a 5-year projection. It begins on July 1 of 2024 for the fiscal year that ends on June 30, 25. So it runs forward for 5 years. And then I have a total column of what happened during those 5 years. So the sources of cash, Measure C, does expire 1 year after the 5th year of this projection on June 30 of 2030. It has a 12-year sunset provision, so it'll be gone. The district tax revenues come from the GO bond, and they're stable here for the next 5 years and thereafter. Third item of fixed income sources of cash is the rent payments from Adventist Health. They will be at $1,750,000 next year, and then they will take a tremendous bump up of $1.2 million to 2,950,000, and thereafter they will be inflated by the CPI index, which I've assumed at a rate of 2%. The uses of cash are also fixed as far as legal agreements. There are 3 of those. They deal with the document in the document of the Measure C receipts and the document in the lease agreement of what's called the Improvements Fund, where the hospital will provide. It started with $2 million of revenue payments into a improvements fund. That fund will be managed by Adventist Health, and they have the authority to pull reimbursements from it. And it's inflated by the cost of living, CPI. So you can see the elevation and the 2% annual CPI that I've built in. Second item are the revenue bonds, and they will continue on for the entire 5 years of this projection. But I'm happy to report on the 5th year, ending in 2029, they will be fully paid off. So you'll be out of debt on the revenue bonds. And then the third item is the Help To loan. It goes across there to the 5th year. Once again, that 5th year amount is much lower because it's the end of that loan in 2029. And very happy, a huge hurrah for, at that point in time, the district will totally be out of debt. There's an existing general obligation bond outstanding, but it does not require any financial obligations from the district. It's all on the taxpayers and their relationship paying tax to the county. So the district would be out of debt in 2029. Then, important thing is to take a look at the total sources, the 3 sources, the total uses, 3 uses, and what that remainder is the cash available for distribution. And that first year, coming up here in fiscal year 25, we have $1,145,000 remaining after sources, subtract uses. We got $1.1 million remaining. How do we distribute it? In 3 areas. The first 2 areas are the down under less distributions. You go to district operating cash. I'm making an assumption, subject to board discussion and ratification and adjustment, of a $250,000 annual budget, along with a district reserve safety net. So basically the budget can be added together as a $350,000 budget for the district, leaving a remainder of $795,000 that has to go into what's called a restricted capital fund per the lease. So that's strictly the remainder after the district is set up to adequately run its business, its operation, and that remainder goes into the capital fund. We'll talk about it here in a little bit. And so you can see that situation all through the 5 years. And I want to point out, it's important to note that let's go back up to uses of cash. Uses of cash. In the total column, during the next 5 projected years, we are projected to spend $11,714,000 on repairs and maintenance at the hospital. A huge sum of money. I'd also point out, let me pull the exact number. We have already spent for the last four years, $6.5 million. 6.5 and add another 11.7 to it. A huge amount of money that we're putting into the hospital. It's needed. I'm not saying it's not needed, but it is a large amount of money to be placed into the facility, and you need to be aware of it and make sure there aren't other alternatives. So, and then down under the restricted capital area, then the totals, we're able to, through the distributions, accumulate $8.8 million into that fund, which is very important. We've got enough of a residue coming from the sources and the uses, leaves a remainder there of $8.8 million, which is quite sizable, going down into the restricted capital fund. So now, moving down into the restricted capital fund, there's an oversight there that I want to acknowledge because of some recent findings. Restricted capital fund should also have a slash to it, / to it, to say improvements fund also, because improvements fund is where we put the Measure C money and we add a contribution to it. So it's going to be a combo fund, a restricted capital fund and improvements fund. It's let me describe those two funds. The improvements fund was a very important funds that were put into the lease. There was a lot of thinking and negotiation around those, and it wasn't one of these last minute situations. It was for the well-being of the district, and it's meant to accomplish that. The improvements fund was meant to be monies put in there from Measure C with some payments from the district itself to maintain the current facility with the buildings and all of the fixed equipment in there. Is way beyond the buildings. It has to do with also furniture, fixtures, and equipment in there. So it's a big undertaking, and we wanted to provide a fund that would be receiving money over a period of time, and that's what it was meant to accomplish. And then the restricted capital fund had its own meaning of only the seismic retrofit activity and or any modernization or development of hospital inpatient and outpatient care. It was really, so to speak, for the future, and the improvements fund was for the present of maintaining what we got. So those funds were of that nature, and they do have funds in them. I'm disappointed some recent findings that I've discovered that the improvements fund was meant to be, the funds would go in there from Measure C, matched by the contribution from the district. They would go in there every year to an account that would be managed and Adventist had the authority to go in there and tap it, and therefore it was meant to be deposits outside of the district. I find that that's probably not happened during the last 4 to 5 years, and those funds have stayed commingled into the hospital, and that's why I have some reservations on what is displayed in the capital fund right now. Is some of those monies are going to be coming out of there and going into the improvements fund, which is fine. Both funds are very equal. They serve their purpose. They've got to be funded well, and it's very important that they're funded accurately because they've got very special and purposes to accomplish. So I'll be going through that reconciliation. Take me a few more days and determine how much of that restricted capital fund, so to speak, the way it's stated, it's not going to change the total balance. It's just going to change the allocation by adding a new improvements fund in there. It's going to be divided with a new activity going in there. So doesn't change the total at all. That's an overview, a synopsis of the report, Mr. Chairman. It's a very healthy report for the district. All of the funds, I'm happy to report, have been consolidated, and as you reported, into a couple of accounts in one bank, and that works much better. It can be tracked. It can be easily accounted for by me and other people, and it's a much better way of doing business for a small business, and that's been accomplished. It was a very difficult task. It involved 2 or 3 board members, a lot of their time and effort, but thank you to all of them. We got the job done and did it very well. So I would pause here for any questions or comments.
Yes, questions from board members. Director Spring.
Where would you say that the TEL insurance and TEL expenses from running the hospital would be in this breakdown?
The what kind of insurance was it, Sarah?
The TEL insurance that we bought, that we're still paying for, the malpractice and then the...
Okay, TEL, okay, fine, I heard, okay. It would be in the $350,000 amount that I have. It would go into that category, that budget, and let me clarify it again. That's my bogey number to put out for discussion. If the board wants to go less, great. If they want to go a little bit more, fine. So it would go into the $350,000 to answer your question.
So, but I think it does begin to paint, give us an understanding of our finances that we haven't had before. Director Kessa, if you have a question?
Yeah.
Okay.
Those two together.
Director Savage? So Mr. Allen, if my understanding is correct, in terms of the investment that we have available to make into the hospital over the next, between now and 2030, is $25 million?
Yes, it is $25 million, but it could be, it could be $5 million going to the improvements fund and $20 million going to the capital fund. I'm just throwing that out there. The $25 million will not change, but there's going to have to be an allocation to the improvements fund. So they'll all go, so just with that caveat.
Yeah, and I guess the point I'm hoping to make here, if I'm doing this correctly, is that we are in a much better position financially than we ever understood before. And I hope that should be a source of encouragement for all board members as well as members of the public.
Yeah, I know, yes, and let me add to that, is I know Adventist is very concerned about their improvements fund and their safety and keeping that building up to licensure standards and so forth. That's a tough job that they're doing, and they need monetary support, and probably this will give them a little more monetary support when I figure out the reconciliation. So it's money well spent, and probably money that they need to run the hospital. And running the hospital is our hospital. It's not going to anybody else. So.
Yes, good evening. Thank you for having us. Tonight we have your full seismic compliance team here present to give a comprehensive update. Michael Terrace is here joining me from Props and Measures. Dudley Campbell is here from Devaney Group. Devin Lombard from Jenkelb. I know I butcher that name. I'm so sorry. And Shin Green is here from East Shore Consulting. I'll start with the update, and then we'll sort of shift to each of us. We have been working with the board since the beginning of the year, since January, a little bit before that in December, but working with the board to schedule and facilitate community outreach meetings. The board has held 6 community outreach meetings throughout the district with the intent of listening to the community. Members share what they value in healthcare services and what could be different regarding healthcare on the coast. We have the board has sent an informational mailer titled Community Update that was mailed to all registered voters in the Mendocino Coast Healthcare District. The mailer provided an update on the hospital district and information about a potential bond measure to support seismic compliance requirements. In addition to the mailer, there has been information posted to Facebook, and we're currently developing some digital creatives to share via online digital ads and programmatic digital outreach to again continue to share information regarding status of the healthcare district. Next, I'd like to introduce Dudley Campbell and his team to update you on the compliance schedule.
I'd just like to state that I had the opportunity to enjoy a dinner this evening with our HCI representative, and he was high praise for our team, which includes Dudley from the Devaney Group and also Denver Lombard from Dagenco. But he thought that we had one of the best teams assembled in the state, so that was very nice to hear. So hopefully, Dudley, with some praise, you'll even feel better about speaking to us tonight.
Thank you, Chairman and members of the board. And thank you, Robin. Update with regards to where we are with the compliance. Carl did give a very good overview of what we have done to date, which is we have done the evaluations and submitted those to HCI for the NPC requirements. And we are in the process right now of formulating our proposals for the SPC, which are the structural compliance elements, which are the Material Testing and Conditions Assessment Program called MTCAP. So we'll be submitting those here in the next week to you and the board for review and approval. And once we have those approvals, we'll start that exploratory effort, design effort that Carl had shown. With regards to the NPC requirements, as noted, we have submitted into HCI the NPC 4 requirements, which are the stuff within the hospital typically above ceiling. That has been submitted and we are awaiting HCI review comments. Once we start to get a dialogue with HCI, we'll be evaluating those solutions and putting together a package again for the upgrading of those components. And then the last item, one of the last items, excuse me, is the NPC 5, which are the water tanks related to potable and wastewater storage. Again, that evaluation has been submitted and we're just waiting for comments. We have received notification from HCI that they've received the information and it's in their queue for review, but we have not yet received any of the comments for that. So once we get comments, then we can proceed into the next stage of design with those items. Devin, I'm not sure if you'd like to add anything to that, but that's my update.
Dudley, I think you covered it all.
Thank you, Dudley. Mr. Chair, I didn't know if you wanted to seek feedback from us individually, or just can we continue with Mr. Green's report and then
Go to
Great.
questions
Thank
from the
you.
board. Yeah.
So in an effort to stay on the path towards a potential bond measure, we have asked Shin Green from East Shore Consulting to provide some different bond program scenarios. If you'll go to the final page of the document, and maybe we can spin that so it can be easily read by the group. And I'll turn it over to Mr. Green.
Thank you. Through the chair, Shin Green, East Shore Consulting. We have created an update of potential bond amounts at various tax rates pursuant to requests to explore what various rates could raise below the initial kind of $40 million target we had discussed. Just want to highlight that at $27 million, we get about $21 million under current market conditions, and scales up as you go up. 36 would provide just under 28 million. $42 tax rate would provide about 32.5 million, and $54 to get to the 40 million. One thing I do want to highlight, those tax rates are per $100,000 of taxable or assessed value. That is the same valuation controlled by Prop 13 that is utilized by the county for levy of all property taxes, which are based on values. And we still maintain the concept of issuing these amounts in 2 potential series split by roughly 18 months. One other thing I'd like to highlight is that with some updates on information from the tax base and some strong growth in the last fiscal year of about 4%, has improved the efficiency of what we can do. We generally have been estimating a 2% growth rate, and so that 4% is kind of twice what we would normally assume. And using that, we were able to improve the efficiency of the $54 model, take 1 year of repayment off, and also sort of reduce the repayment requirements and repayment ratios. Interest rates are also a little better now than when we initially ran these models on the tax exempt side, although marginally. But we do hope that that trend continues and we can provide additional efficiencies in the future. If there are no questions, that's all I have to present.
Board now. Okay, I hear none, so thank you very much for these reports.
Mr. Chair, I just would like to, thank you, have final comments. What we've heard tonight, lots of really good information, and While we know the path forward is not 100% known and legislative action might bring some relief to the compliance schedule, what we have heard is that there is and will be a mandate to upgrade the Coast Hospital to meet seismic compliance. And pushing this project down the road will cost more to complete it. In order to help the board in the decision-making process about potentially placing a measure on the November 2024 bond or pushing that out to 2026 or later, we'd like to recommend the district bring back EMC research to conduct a tracking poll to gauge the support in the community to update the hospital. Just to give you a reminder of timing, the deadline to submit a resolution to place a measure on the November 2024 ballot is August 9th. If the board decides to conduct a tracking poll, that poll should be in the field in June in order to allow ample time for EMC research to conduct the poll, analyze the results, and bring those results back to the board and the community.
Piece of information, and I think the board is going to need to go to work on making a decision on that very shortly. So thank you.
Thank you.
Quick question.
Director Savage.
Well, a la what she just said, and I don't know if it needs to be future agenda items to consider, or did we already? Because a tracking poll was discussed in the original proposal. At what point do we make that decision? Do we make a motion tonight to proceed with
Well,
a tracking poll?
we can't make a motion because it wasn't agendized for that.
Correct.
But we can request that we're going to have to do something fairly quickly. So most likely, I think we're going to need to. I think we're going to need to do a special meeting. We need to get that scheduled.
Okay.
Okay. Does that make sense? And I'll
No,
commit that
I just wasn't sure when that was going to happen.
We'll do that. Yeah. No, I appreciate the fact you're raising this. This is, a timeline is very, very important here. And I appreciate that. Thank you. Thank you for your reports. I just want to observe that I meet regularly with this group of consultants. Typically, it's Wednesday morning, and it is my favorite meeting of the week by far. So thank you for all of your good work.
Thank you.
With that, let's go back to Mr. Allen. This is this issue of this CARES Act reimbursement liability is a very important one, and he's done a lot of work on it. So, Mr. Allen, let's take us back to that, please. Or take us through it, I should say.
Yes, let's get into the document. It deals with the CARES Act of 2020, and that was a federal law stimulus program to aid the healthcare industry, and it included $2.2 trillion. So it was a huge effort. And on page 1, our share of that among all the other 4,000 facilities was down near the bottom of 1,461,000 on April 17th, 2020, and then 4,300,000 on May 6th, 2020. Those are the two large payments. They're called targeted and general distributions. They total 5,761,000. The other smaller grant that was given came in to do the rural health testing, and it was 49,000. So the total of all three distributions was 5,811,000 was the money that the district needed to account for by either having expenses directly related to COVID activities and or lost revenues. Your business went down and you lost revenue, and you can claim that. Page 2 deals with an item at the top that I want to point out is there were 7 period, they call them period, in the government, And there were 7 periods, and we only qualified for the first one because we ceased operations. And the first period was from April 10th, 2020 to June 30, 2020. So you can see we got into that and received that 5.8 million. And then, more importantly, we have from the period of January 1, 2020 to 18 months later, June 30, 2021, to prove to the government that we had lost revenue or we had expenses related to COVID. 18-month period that we had to have that revenue loss or that expense incurrence. Going to move to page 3 and deal with a situation that's kind of bothersome. Is I put there in the very first bullet point that the prior board, prior board on June 14th of 2021 engaged a consulting firm called FTI. I don't even know what it stands for, but FTI Consulting, to help them with their reimbursement documentation and also help them with their reporting into the portal. You have to go onto the computer and get a password and report all of your information into the portal. And then I'm interested in that report. And I found out a couple days after I had finished writing this that I added another bullet point that I found out what appeared to be an Excel document that this FTI group had prepared. And so I looked at it, and it had some calculations in it. It wasn't alarming to me. It was a typical calculations I would have made. So it was well done in that respect. And then it down in the item, the problem with it in item B, I point out, is it didn't have an identified author or it wasn't dated, but I've been told it was the FTI document. So found it a little sloppy in that regard. But then in item C, it came out to show on one of the tabs that I've photocopied and sent it with this attachment that there was a repayment liability they computed to be $1,088,000. $1,088,000. But then they had it as subject to a couple footnotes. So that led me to the conclusion that this was still a draft document. And I have not seen the final document. I discovered probably about a week ago another FTI document, but it's merely a nice little slick presentation of the rules and the way you have to fill out the portal. And it's just a copy job from the HHS documentation. There's nothing in there to do with calculations, so not very helpful. And then on that last bullet in that area that I'm right below item number D, I found the minutes of the October 28th, 21 board meeting and in there, Treasurer John Redding had made a statement about the 5.8 million was received, fine, and apparently this comprehensive audit he calls by their consulting group documented they could account for 4.4 million. So that leaves a balance of 1.4 million. That's a liability. That's different than the 1,088,000 I just cited. So I point that out, that there's another different liability. And then in the documentation that a copy of the documentation from the portal that I obtained is reports that the liability is 0, and it has John Redding's name on there as the user, and I find out he is the one that has the user password. And I don't know whether he submitted the portal information. Have no substantiation of that. But in that reporting, which had to be done by November 30 of 2021, it has to be done by that period, a long time ago. I don't know if they met that period or not. They were using this consulting firm during that time, before that time. So I'm thinking that was a hurry up and get the documentation and meet the November 30, 21 deadline. But I don't know whether they filed it at that time. Anyway, it was filed, and lo and behold, it shows a 0 liability. No liability at all. So here we have a third situation, and that's incorrect, because the way Mr. Redding had filled it out is he claimed lost revenue for the calendar year of 21 in his calculation, and the hospital was not providing patient care in 2021. Of course, it's going to be zeros. You can't claim that, and he did. So if you remove what he claimed erroneously, and with the other numbers he filed, I have near the bottom of page 3 in bold, the liability really comes out as 2,146,000. Here we have a fourth number. So if you're confused, I don't blame you. So there's 4 numbers out there floating as liabilities. And the point at this point would be that once you report it in the portal, it's official. It's gone to the Department of Health and Human Services that administers this program, and you cannot change it. It's subject to audit, and the auditors will come in and say, is that right or not wrong? And then they'll issue their opinion, and my judgment, when the auditors do that, they're going to issue the opinion that it's been filed erroneously, and we'll have to do a correction at that time. But that's the only time it can be corrected, when the auditors come in. And that hasn't been scheduled yet with our auditing firm. And so stay tuned on that. Page 5 is all I've done is offer a conclusion here of listing the 4 different liabilities. And the only one that I point out that really is official is the one that reports no liability, which is very interesting. And I point out that a prudent person or prudent people looking at this would not probably come to that same judgment. So, and the other thing I need the final copy of the FTI audit report. I don't know if it exists. I don't know why Mr. Redding quoted that it was going to be 1.4 million, but I don't have any FTI audit report. My attachment is a copy of the Excel 2 tabs out of the 19 tabs in the workbook, where it shows the $1,088,000 that they've arrived at as a liability. And then it shows some outstanding items, which I led to the conclusion that the report was a draft report. So it's a work in progress. It's got some very negative ramifications to it. There's lots of issues there with anything has been done deliberately. There's severe ramifications, and so it's not a good scenario. That would be my conclusion, Mr. Chairman.
Appreciate your work on identifying all of this, and it's something obviously we can't, it's not going to be resolved quickly or easily, so we'll look forward to future reports on this. Now, okay, board questions?
Wayne, would a COVID-19 related expense be all the unemployment that we had to pay?
Just a moment. Yes, probably so. There was other situations I've dealt with where the staff was kept on board. They weren't needed, but they were retained in their positions, and they ran that through as a cost and got approved. So the unemployment would be the opposite scenario, but it's same situation. So my judgment on that would be yes, it could be included.
Okay. Any other questions? I understand from talking about this on the phone with Mr. Allen that he is working hard to see if there are other things that could justify that difference between what was claimed and what appears to be owed. And so this is just tentative, but of course it's such an important issue to the board that wanted to open it up and make everybody aware that this work is being done on this. Does that make sense? If there are no more questions, then let's move on to item 5D.
I just wanted to say, I don't
go
have a
ahead.
question. I just want to say thank you. It's an incredible piece of forensic investigating. And I hope you enjoyed it. Seems like you really got into the weeds pretty deeply, maybe 25 clicks in. So thank you for doing that tedious work for us.
Thank you for your comment. Appreciate it.
Okay, we have item 5D, which is the renewal of our, from Beta Healthcare Group Professional Liability Insurance. Any questions? So you have the item before you. The total amount is $25,495 for the year 2024 to 2025. Is there any, did I quote that correctly?
It's both. There's two.
Yeah, the total contribution is $25,495. Yeah, you did get that right. Okay, so questions?
Did we put this out to other insurance companies besides Beta?
I was going to wait. We did not have any other insurance companies bid on this. CFO Allen and I talked about that, and Wayne, would you remind me, we talked about a different health insurance company that might provide the service, but it did not. Basically, we were trying to figure out who covered the facility, and that's covered by Adventist. And so, to answer your question, we did not explore another bid.
Okay. Other questions?
I've tried to put this out to bid in a couple other places, and Beta is so strong in the healthcare industry and has excellent pricing that the commercial carriers, some of them would not even bid, and when they bid, their rates were ridiculously high. So Beta has got a lock on the healthcare industry. And they do a good job. They do an excellent job. I've dealt with them on claims, and this hospital has had a very, very major claim back in 2019, 2020, and they stepped up and paid a considerable amount of money. And I watched their team in action going through arbitration and negotiation, and they do a wonderful job.
Thank you. Other questions from the board? Okay, public comment. Mr. McDonald.
Because this comes up every year or almost every year, I wondered who handled this discussion, negotiation with Beta last year. Does anyone know?
It was Jade.
So my second half of that is, did the treasurer take part in this year, or was the treasurer informed? Understanding that we have Mr. Allen to do CFO work, but this is kind of like some of the things in the internal, quote, internal controls policy. If this is something that's been handled by treasurers in the past, shouldn't it be reported to the treasurer in a, normal amount of time? Is my question.
Okay.
Was it reported to you? No.
Any other public comments online? We have anybody online?
We do not have any hands raised online.
Okay. With that, do we have a motion to approve this bid from directors and officers liability from Beta?
I'll move it.
I'll make that motion. Somebody.
Okay. Director Katzoff moves. Is there a second?
Oh, I'll second that. I said I'd move it, but I'll second it.
Okay, all right. I'm sorry, I missed your, unfortunately, I hear much better on my right side than I do on my left, so I apologize. I did not mean to exclude you. Okay, any additional comments from board members at this point?
And just point of clarification for the vote that we're voting on the professional quote, because there were two different quotes here. Or are we doing them both as a package?
Yes. I thought we were doing them both as a package.
Yep, as a
Okay,
package,
got
yes.
it.
Okay, and I misquoted the amount, I'm sorry. It would be 25,000
It's
for 95
37,000
plus 11,561.
Right.
Correct, yeah. Okay. Roll call?
Okay, Susan Savage, yes. Sarah Spring,
No.
Paul Garza,
Yes?
Paul Katza,
No, I'm surprised. So here's something interesting. You know something that I don't know. And like I've said many times, that at least once I've said, why are you voting no? Maybe I'll change my vote. I was going to vote yes, as if it was a slam dunk. We didn't have any discussion that led me to believe that there was an issue here. Do you want to inform me? You don't have to.
Because there's another insurance company, SDRMA, that writes these policies all day, every day, that I bet was not given the possibility to get a quote from.
Okay, and that's okay. I'll vote yes.
Okay.
But thank you.
I'm sorry, you'll
Yes.
vote?
Yes.
Got it.
Okay, let's go on now to our next item, which is the review.
5E.
I think,
5E?
yeah, 5E, review and approve board policy, distribution of districtly owned property, surplus, et cetera. This is not the most exciting policy in the world, but frankly, I just want to comment that we have been trying to dispose of our surplus, and we're paying fees for this. And so hopefully we can get through this policy tonight so that we can finally get that cleaned up. But obviously, we need the wisdom of the board on this. So any board comments on this particular policy, policy number 11? Okay. Okay, comments from the public? Okay, hearing none, I guess, do we have a motion to approve policy number 11?
I'll move it.
A second?
I'll second.
Okay, roll call?
Okay, Paul Katzif,
Yes.
Susan Savage, yes. Sarah Spring,
Yes.
and Paul Garza.
Yes. Okay, Mr. Allen, we're back to you now.
Okay, great. Let's start with the bank balances, and very quickly, we're talking about the month of April, and you have the listing of the banks, and I would just make a notation that in May, the Tri-Counties Bank will be listed and Leaf will be listed. The other two will be gone. So we're down to that situation. Let's move on to the Treasury bill inventory. I was finally able to get all the authorizations and approvals and board signatures to get into the United States Treasury, and started that with the first purchase date of May 7th. And I'm only buying 4-week, 28-day Treasury bills, trying to see what these interest rates are going to do for the next 2 or 3 months, trying to play it very flexible. And so I've been able to get in there with purchase. I have to submit a purchase order on Tuesday or Wednesday, and then the auction is on Thursday. And then I get notified on the following Tuesday whether the order was accepted. Many of these auctions lately have been oversubscribed, and if you don't get your order in quickly, then you'll have to try next week. So, and they're weekly auctions, and so we've been successful for 3 weeks in a row, and the interest rate I've not seen being this stable in many months. I mean, it's just holding at 5.365 basically. So it's and that's a good high rate, and so we'll see. And then the way Treasury bills work, I've mentioned this in the policy, but you go in with a par value that you're putting up, and then they discount it to for the interest in investment income, not interest income, investment income, and we only paid $2,987,000 for that purchase we made. Then on the maturity date of June 4th, we will be getting $3 million. We get our purchase price plus the investment income, and then it yields our par value. They give us what I had as par value. So that's the process. I've got a bid in today for another $1 million, and I'll know on Tuesday whether it got accepted. But hopefully it did, and that'll bring this par value to $10.5 million that we've got in U.S. Treasuries, scattered out every week. And that the key thing for the last year to 2 years really is, and several people have got stung doing otherwise, is maintain flexibility. Keep your options open to a 1 month, 2 month, 1 week, 2 weeks, where you don't get stuck with 1 year, 2 year, 3 year maturities. It's too markets are too volatile at the moment. So we're well positioned to turn the old ship around on a dime, and that's what we want to achieve. You can see the interest income already, investment income already is $38,000. We will realize for that $9.5 million, and that's just for 4 weeks. You take this and multiply it by 13, and you then get it close to $500,000 of interest income. So I heard Paul Kay earlier talk about interest income, so I'm sure that'll perk his ears about how this investment income can really generate a lot of dollars for the district. So that's my report on that, and let's go.
Before we go on to the warrant list, do we have any questions from board members about this? Okay, hearing none, let's, Mr. Allen, the warrant list.
Okay, the last page is the warrant check register list. I prefer to call it a check register list because that's what boards are doing now, is they're reviewing what's really happened by name and date and amount in the activity. And if there's something suspicious or they ask for what the justification is and then see what action needs to be taken. So it's more of it's a check register instead of what used to be called warrants. And so I point that out to you. It's on page 2 of it, or if you've got just one page, I want to highlight something that's interesting to me because near the end, the third United Health, clear near the end, we have paid off the United Health loan of with a payment of $216,000, and that was a 10-year activity that happened in April of 2014, and I'm the guy that signed that loan document for $2.1 million. So I'm glad to see we paid it off. So it's a small world when you see something like that. So anyway, then they totaled for the month of April $363,000. But we got a large amount in there for United Healthcare, and then we got a large amount that'll always go through for Bank of New York Mellon. So those are the two large payments, and the rest of them are kind of rather small.
I think what we've been treating as a warrant list are expenditures that require some sort of board action to approve moving forward. And so I'm guessing from the looks of this that there really isn't anything out there that was happening in the month of May that you need board authority to go ahead and pay. Is that correct?
That's correct, and your rationale is correct. If there's something that is not under contract or not normal, it comes to the board for approval and for payment. And there wasn't anything that I observed during the month of May, but that would be the process. Then they bring a warrant or so-called meeting approval to the board.
Question had to do with April 29th, that there were 2 checks made for $13,200 to RGS. Were we catching up there? Is that what was going on, or why there were 2 in the same month?
On the same day?
Yes, we have been catching up. There were in arrears for 2 or 3 or 4 months. There was a considerable in arrears for that vendor. So.
Okay, Director Spring.
Wayne, will you be bringing forward the legal bills for us to approve?
Just a minute, Sarah. Yes, I will be, because those are they're not routine. And they can be very, very high dollar amounts, and they're not a routine expense. So yes, they should come to the board for approval.
Okay, other questions by the board members? Okay, so this is an action item. Mr. McDonald?
Director Spring can correct me here, but I think that in early 2021, at least one member of the board recommended paying off the, I don't want to say small because, but the relatively small long-term debt payments. And then now here we are paying over $200,000 to finish off the United Healthcare debt. Just think historically that needs to be noted that it was sort of ignored for,
Years,
yeah, almost
4.
about 3 years plus. And the 216,000 and the rest of it, I don't have it in front of me right now, for United Healthcare, who also authorized that besides the CFO, considering that it's above the numbers that I think are just, you know, the regular and customary
My
amounts.
understanding was that that was not approved by the CFO. My understanding that was approved by Director Spring and CSDA employee Rick Wood.
I also discussed it with Wayne prior to making the transaction.
Okay, with that.
That's correct.
Okay, do we have a motion to further comments from the board? Seeing none, we
Could
have a
I
mo-
comment on what Malcolm said? You got to evaluate paying off loans with what the interest rate, investment income percentage is doing. And since 2022, 23, and 24, you can earn 4 or 5% on your money, and the UHC loan was 3%. So you leverage that. So it's got to be a relationship there, Malcolm, between what investment income percentages they're doing, and then in the past, like you said, for the last 8 to 10 and 12 years before that, interest rates were 0. So if you could pay off a loan, you were better off. So.
Comments, let's, do we have a motion to approve the, I guess we should, warrants or check register?
Anybody know what temperature it is in this room?
Pretty cold.
Yes,
That's
it's
what
Really
it is.
cold, and I want to get out of
They
here.
want the meeting over, is what it is.
Yeah.
Okay,
you've
I
got
will
a
make the
move of
motion.
approval?
I will make the motion.
Somebody moves, I move that we
Did you move
approve.
approval?
She did.
Yes, I
Yes,
do.
yes,
Okay.
second?
I second it.
There you go.
Okay, roll call?
Paul Garza,
Yes.
Paul Katza,
Yes.
Susan Savage, yes. Sarah Spring,
Yes.
approved.
Okay, thank you. With that, we're at the conclusion of our business tonight. Do we have a motion to adjourn?
You don't want board comment?
Sorry, Chair, comments from the board?
Oh, sorry, I'm sorry. Yes, comments from the board. Sorry. I was just thinking, my God, I'm freezing, I'm going to get out of here. Comments from the board? Director Spring?
I would like my 4 other board members to know that I have not been involved in one single financial transaction in about a month. So, except for paying that loan payment that needed 2 approvals and doing things that Wayne has specifically asked me to do, i.e. resetting his PIN or Kathy needing me to reset her PIN. So I have no idea about anything that is going on with anything to do with money. I have not seen an invoice, I have not seen a check, I have not had anything to do with anything that is the treasurer's job, in my opinion.
Any other comments from board members? Okay, do we have a motion to adjourn?
I make a motion that we adjourn at exactly 9:30.
No, you have another
You
minute.
gotta talk slower.
Okay, if I gotta be cold, everybody gotta be cold.
Okay, do we have a second?
I will second.
Okay, roll call?
And I'm warm.
And by the
so
end of the
I'm
roll
trying to
call,
be
it'll
good.
be 9:30.
Okay.
Okay, Susan Savage, yes. Sarah Spring,
Yes.
Paul Garza.
Well, I have to wait just a few seconds.
No,
so we can-
I'm the
Yes.
last one.
You can sit there for the next minute. Paul Katza.
Yes.
Okay,
And we are
thank you.
adjourned.
Thank you, board.
Please note for the record, the meeting has adjourned at 9:29 PM.
Thank you, Norma.